So, anyway, welcome everybody. Different person. Okay. Okay, right, well, we're going to hopefully carry on.
Feel free.
Okay, and at some point I will sort this out. Okay.
No.
We're going to get that. Right, so it is. So, major technical moment. Okay. Okay, so... Right, can you all hear me?
Yes.
Do you all know that I'm me and I'm not someone else? Good. Right, I don't know quite what happened there. Anyway, so welcome once again. And I'm now going to ask the panel members to introduce themselves so that you know who we all are. But then anybody who's not on the panel, if you can introduce yourself when you speak, I think that would work very well. So my name's Dina Romero and I'm the chair of this panel, and I also represent Southdown in Bath.
Good morning, my name is Liz Hardman. I'm vice chair of this committee and I represent Porton as the ward councillor.
Good morning, I'm Michael Orton and I represent Midsummer and Orton North.
David Harding, representing Chew Valley Ward.
Paul Crossley, councillor from Southdown, Bath.
Morning everyone, my name's Leslie Mansell and I represent Radstock.
Morning, Christopher Batten, representing National Education Union. Thank you.
Good morning, my name is Kevin Burnett. I am the Professional Association rep for the NEHT and a non-voting member of the panel.
Thank you very much, and Chris is also a non-voting member as well. So, without further ado, I will invite Mark Durnford to read out the evacuation, and you might as well introduce yourself as well.
Good morning, everyone. My name is Mark Durnford. I'm the Democratic Services Officer for the panel. And if you hear the continuous alarm, you must evacuate the building and proceed to the assembly point. From this room, you follow the green running person signs to the exit. You use either the marble staircase or the main staircase. Please not use the lifts. The assembly point for this building is the Orange Grove grassed area, just outside Brown's Restaurant. And there's an evacuation chair for use by disabled people who so wish in the corridor outside the Council Chamber Public Gallery. Alternatively, the area at the top of the marble staircase has been designated as a safe refuge where persons needing assistance should assemble. Thank you, Chair.
Thank you very much, Mark. Okay, we now move on to item 3, which is apologies. So I have 3 to note at the moment. I've got Councillor Onkar Saini, Councillor Barrett Pankania and Councillor Joanna Wright. Are there any other apologies?
None that I'm aware of, Chair, no.
Thank you very much, Mark. Declarations of interest. I've not been notified of any. Does anybody have any declarations they wish to make? No, thank you. There's no urgent business, and now we move on to public and councillor statements and questions. I do have that Wendy Lucas was going to speak. She may be running late, in which case, if she arrives, I'll bring her in before the respite item. And Councillor Eleanor Jackson, did you want to speak now, or do you want to speak in front, before the item?
I'd like to speak before item 7, please.
Okay. And there has been a question that has been circulated, and I believe the response has also been circulated. Thank you. Okay, so we now move on to the Cabinet Member update. Thank you, Alison, for giving us that update. Is there anything you wanted to add to it?
No, I mean, just to say the report describes some elements of the continuous improvement programme that we're working on with the services that we've brought back in-house. And over recent months, we have reduced waiting times both for assessments and for reviews. And we're just about to start a focused waiting time initiative using agency staff. So we're hoping to make some quite significant progress on that in the next few months. We're also focusing on quality improvements in our care homes and extra care housing and learning disability services. And there's a big focus of activity on those. There's a bit of an update on the work of the Ageing Well programme, which is being led by the local branch of Age UK. And as part of that, there's the development of a local dementia strategy and pathway, which is linked to the Ageing Well programme work, and it will be linked to the ICB dementia strategy. And the members of I'm involved in this process, and also officers in the council are. So there's good representation from the council on the Ageing Well programme. Just in relation to the public health section of the report, just a few really positive things to note. One is that last year's Director of Public Health report was chosen to be one of the top 5 reports in England. So that was really good to hear, and a great credit to Becky and her team for achieving that. And we've also last week had a visit from the OHID assurance team. So it was a visit by the Regional Director of Public Health, who was looking at the quality of our public health services and the value that they deliver against the public health grant. And in the letter following that visit, he referred to the brilliant work in our authority, which again, really satisfying to hear that. And then the last thing I'd just like to highlight is to encourage panel members to contribute to the pharmaceutical needs assessment, which is running until the 1st of July. That's something that Public Health is required to do every 3 years. And I know from casework that there are quite a lot of concerns about shortages of pharmacy provision. And certainly I think we've had some pharmacies that have been closing at short notice and then reopening erratically and then possibly closing permanently. So I think it's really important that we get a clear picture of what the provision is, so that if there are shortfalls, there are opportunities to try to address that. Okay. So thank you.
Thank you, Alison, and I apologise for not allowing you the opportunity to introduce yourself. So, for everybody, that was Councillor Alison Bourne, who's the Cabinet Member. So, do we have any questions for Alison? Liz, and then Kevin, and then Paul.
I would also like to add my congratulations to the public health report, where our public health team have been awarded, as you said, Alison, in one of the top 5 out of 67, but it's on food security, and it's really good to see that, so well done. My question is on page 5. And I wonder what the difference is between an unscheduled review and a review. And are unscheduled reviews just it's something that happens but not officially and it's added into the official lists, or how does it work out? Thanks.
Morning everyone, I'm Suzanne Wester, Director of Adult Social Care. So an unscheduled review is usually maybe somebody needs their package of care reviewed and changed because their needs have changed, so it's unscheduled. And then the scheduled review is that yearly review that everybody receives. And they're not usually the definition is really clear about how we can count reviews, which is set nationally. So I hope that's...
I think so. So an unscheduled review is something that happens when somebody's needs changes, and so it has to be done straight away. Yeah, I get it now. Thank you.
So next I have Kevin and then Paul.
Thank you, Chair. Yes, a few questions. One for yourself on adult social care, and then I think a few that may come under public health bit as well, please. The first bit was the adding congratulations and well done to the public health team on both of those things this morning you've mentioned. A time of increased demand and you're achieving reduction in waiting lists, well done. Just wondered what strategies you're employing to do this, and are they being used elsewhere, or can they be used elsewhere? Are they transferable strategies and the achievements there? And the other bit was around, first of all, the pharmaceutical needs assessment. I couldn't see an explicit section. It might be if being implicit amongst the text, and I apologise if I've missed it, but I couldn't see a sort of little section that says this is the criteria on which we're judging sufficiency of provision. So, you know, for example, if you travel by car with 50 minutes to get to a pharmacy, that's okay, or whatever the criteria you're judging it on. So that apologies for that. The other thing tied with that was that it might have been the ICB that mentioned it, but there was a pharmacy strategy mentioned last April, and I didn't know whether that's actually now come out, awaiting this, or where these two things fitted in. And again, I may have been totally asleep and missed it. I understand the shoe survey is coming out soon, so if you could just confirm that the results of that are coming out. And the holiday activities programme, how many are of the eligible people actually take part? You say how many sort of people may be taking part, but of the eligible total, are we capturing everybody, or is there a significant proportion that we're missing still? I think that's it. Bless you. Thank you.
Okay. So your first question, you were asking about the strategies that we have in place to be able to manage the improvement plan, and whether we can actually continue to manage the demand as well as try and decrease the waiting time. And are they transferable strategies? So what we have at the moment is we've got extra social workers, extra OTs to help us manage that And as, let's say, we move past that and we get to, we'll never get to nil because there'll always be a demand. We can move those resources around. We have the authority to use those resources around where they need to be. However, it's not just about that. We have to be sustainable. And the other area we're looking at is AI and magic notes in particular that will really support our frontline practitioners so that when they go out to somebody's home and they put the phone in front of them and they say, actually, we're recording this now, and the assessment will become live quite quickly and we'll be able to send it back to you. So previously what the social workers were doing was they go out, they write the assessment, they come back, they type it all in, and then they send it to the person. And it's really, quite laborious. So we're trying to think of different ways we can support our frontline staff and that the residents get a better outcome as well. So it's IT, technology, extra staffing. What I'll need to consider, and it'll be at the end of this year, is do we need to put permanent staff in? Because I've talked about agency, and that's fine now, but actually to make it sustainable and to manage the demand, will we actually need extra staff? I'm not sure yet until I see how the waiting list goes down, because it's slow to go down, and I would have wanted it to be much faster because of the increase in demand. So I'm coming back in September with the full improvement report, and I think that I'll get you a better feel of how we're doing then as well.
Thanks. Alison, sorry, did you want to add something?
I was just going to say, in relation to the questions about pharmacy and holiday activities, I'm going to defer to my public health colleagues, but also the pharmacies. Public health has got a responsibility to do the needs assessment, but the provision of pharmacies sits with the ICB, so it's a shared responsibility, and Laura may want to add something to that as well. So I'll hand over.
Great. Morning, everyone. I'm Amy McCullough, consultant in public health for the public health team here, as Becky is on annual leave this week. In relation to the needs assessment, there is that criteria there. So things such as distance, ease of access by public transport, opening times, all of those things are essentially mapped, reported and analysed. So that is definitely there. In terms of ensuring that the criteria is explicit, I will take that back to the team that's leading on that to ensure that it is. I know that it's gone out for consultation, but I think in the documents that we produce, we can ensure that that's explicit. I've undertaken one in the past, and certainly kind of criteria around distance, etc., is really important, particularly where we have rural areas. In terms of strategy, I might ask Laura to pick that up, if that's okay, and then I'll come back to HAF.
Good morning, everyone. I'm Laura Ambler. I'm the Director of Place for Baines from the Baines, Swindon and Wiltshire Integrated Care Board. As Amy was saying, that pharmaceutical needs assessment is really critical to inform the strategy around provision. We spoke before, you're quite right, Kevin, around there is an ongoing pharmacy review. The outcome of the pharmaceutical needs assessment is really important in informing that review. And I know we've had a number of questions from... Sorry, is my microphone cut out? Am I still there? Still there. And quite a bit of local intelligence around what's actually happening on the ground in terms of opening times, for example, and some of those changes, as you were referring to, Councillor Harman, that happen intermittently. It's really important that we have that intel and that information, because that obviously gives us then the broader picture. So the pharmaceutical needs assessment will inform that strategy, and at the moment that is ongoing. It hasn't concluded.
Thanks, Laura. And just to add that obviously there's quantitative analysis, but the qualitative part is important as well. So a member of my team is currently organising mystery shopper visits to community pharmacies, including with young people as well, to gather intelligence. So all of that information is then triangulated as part of that needs assessment. In relation to HAF, I'm afraid I don't have the data on the proportion of eligible families that are currently accessing that offer, so I will go away and get that information. Marcia and my team will have that, or in our team, Becky's team. One of the actions for this year linked to the educational attainment work is doing a piece of qualitative work to understand barriers to accessing HAF so that we can then increase uptake. So that piece of work will be really important, and we'll get back to you on the proportion currently accessing. Thank you.
Thank you. And I think actually that report on HAF would be quite useful for our next meeting, which focuses on children's services. So, thank you, Amy. Right, next on my list, I have Paul, and then David, and then Leslie.
Thank you very much. It's not actually on the report, but my question is something that's coming up in the September report. Is the Cabinet a member or the staff, what is the situation, or are they aware of any issues around child sexploitation or modern day slavery in our authority area?
haven't got any information here and now, but there is a group which sits under the Safeguarding Board which reports on child exploitation. It may be something you want to bring in for the next panel.
So I think we'll have that at the July meeting. It's been on our working plan for a little while, but of course it's particularly child exploitation has been in the news very recently, so it'll be very pertinent, I think. Councillor May?
I'll reply to Councillor Crossley, Direct Chair. There's some members of the public waiting outside.
Oh, are they? My apologies. Would you like to invite them to come in?
I'll go and get them. Oh.
Thank you, Paul. Does that answer your question, Paul? Okay. It is, I know. Okay, so my next, I think Leslie, you have, sorry, David. No, you're before Leslie.
Thank you. My question is really for Suzanne and Alison, I think, not related to the reports, but something that perhaps could come back at a later date if you don't have this information, which you may well not. It's really about the changes to PIP qualification upcoming in the welfare bill, because the reduction in successful PIP applicants will also cut the number of people received in carers allowance. This is going to have a knock-on effect potentially on A&E, supported accommodation, even care homes, potentially. So have we got an estimate of the numbers likely to be affected in Baines, the potential effects on the various families and the increased costs for Baines if people need more support from different areas that they're going to have to access potentially?
I'm sorry, Councillor, we don't have that information, but actually might be something for the September. Things will have settled more by then. We've heard some stuff nationally about what's happening around workforce. We've also about funding for next year and the different reforms that are coming through. So I'm beginning to think, as you're talking, that could be something that we could do with the improvement plan, have two different reports about the implications, because we don't have all that data yet, and actually we need public health colleagues as well to support us on that. But it could be something that the Chair may want to consider bringing to September. And you think how a report like that would be written, because there's so much.
I think that would be a very good suggestion, actually, that it comes back to the September meeting, because there's bound to be a lot of unintended consequences as well that we just really need to be aware of. And I absolutely get that you won't be in a position where you know everything, but I think an update would be really helpful. Thank you. Leslie.
Thank you. Thank you for the report, and also it's brilliant to see that the services in Baines are getting national recognition, so congratulations to Becky and her team. What we don't really see is all the hard work that goes into getting us there, so it's good to be able to mark that. On the waiting times, I think it's really good that we've got some of these decreasing. It would be helpful to have a little chart of them, because at the moment we've got lots of figures embedded in the report. So, for example, if you look at the deprivation of liberty safeguards, this has gone down by my calculation 11%, but we can't see that from report. We've got a set of figures. So it'd be good if we can have that as well, so we don't have to pick it all out. On the Dole's backlog, what's the timeline for the newly trained best interest assessors to begin reducing that? On the next page, adult regulated services. So the mock inspections that were carried out in relation to the CQC, how are the action plans going to be formulated from that information into ongoing service improvements? And what are the milestones in the CQC action plans, and how is progress being tracked? And moving on, what are the key priorities for the new carers strategy, and how will its impact be monitored? And on the holiday activities and food programme, how will this be adapted to meet the needs of disabled children and those in deprived areas? Thank you.
Can I use yours? Yeah, of course. So your first question was around the BIA trainers, and they're in place now, and we will continue to monitor. We will never, I haven't seen anywhere nationally where they've actually got down to nil around outstanding BIA, because there are so many people and very little resource to support that. So I'll take that away, and then in the next report in September, what I'll do is put the table you suggested, so you can see the percentages and you can also see the improvement. So that was the first one, and then you asked about the action plans and how we're monitoring action plans, both for regulated services and for the improvement plan. For regulated services, each care home and extra care housing has an improvement plan. There are monthly meetings that are tracking the improvement. With each part of those delivery plans, then there's dates and schedules for areas to be achieved or not achieved, if you like. And if they're not achieved, then we move them forward to get them to achieve. There's a lot of governance around this to ensure that, in particular, the two care homes are moved from alright to good. We can share some of that governance with you in the next meeting as well. And for the carers strategy, Callum, who's here with us today, will be presenting the carers strategy and the delivery plan around that. And I didn't hear your last question, I'm sorry. I think it was around children's.
Yeah, so this is about the food strategy and holiday activities. So how will this be adapted to meet the needs of disabled children and those in deprived areas?
So we do have SEN-specific sessions, or some with SEN are supported with one-to-one staff at mainstream sessions where that is needed, and that offer certainly is there for children and young people with disabilities. So that offer is there. If you would like more detail on that, I can ask the team that's responsible for delivering that. So that sits with our children and young people's team. I'm just in conversation with Claire, who delivers and who commissions that service. So if you maybe come back to me in a couple of minutes, I can provide a little bit more detail.
That would be great, Amy. We could also add it on to our next meeting's information, perhaps through the Cabinet member, as of course that meeting is focusing on children's services.
Right. There is, just to add, so there is a specialist provider, so that supports that area. So there is, there's that generalised offer, but then there is that specific area that is commissioned. So yeah, we can come back with further detail as to what's in that offer.
Thank you. Have I missed anybody off my list? No, then I will ask my question, which is around access to leisure activities. And I note in the report you talk about it seems a bit unclear how many of, within an area of deprivation are not taking up any form of activity, and it'd just be interesting to learn what are those barriers for those who are in an area of deprivation, because an obvious one clearly would be around cost, but are there any other barriers that you've been aware of that as a council we could be addressing?
So I'm aware of barriers around timings. So in terms of particularly for those parents where they are working, so that's one barrier that's been raised. So the hours are too short, essentially, a offer that starts at 10 and maybe finishes midway through the afternoon is not long enough for those working parents. So that's certainly one thing that's been raised. Another thing that has been raised has been around transport. And then essentially we'll do that piece of work where we try and do that deeper dive through the qualitative work to understand further barriers.
Thank you, Amy. I was also looking at not just the HAF part, but the piece around physical activity and leisure services. So it's a slightly broader question.
Yes. So, again, some of the barriers that have been raised, and we will be doing further work, obviously, around the physical activity strategy, so further consultation work to inform that. So, again, some of the things that have come up in the past have been around cost. Cost does come up, so that is a factor, a really important factor that we have to consider. Costs obviously vary across our different leisure offers. Again, transport does come up, so that's where consideration about obviously having different leisure offers in different communities is so important. Not everybody is able to travel to some of the leisure offers easily. Something that also comes up through kind of more qualitative research is inclusiveness and sense of belonging. So those are also really important factors because obviously we want to ensure that our leisure offer is not only accessible, but everybody feels that they are able to use them and kind of belonging in that place. So those are some of the things that have come up. And then there's a qualitative component to the physical activity strategy or framework work that's going to be taking place to do a deeper dive, and some of that will be will ensure that we get that kind of general feedback across veins, but we're looking for that kind of community place specific feedback as well.
Okay, and so my related question then is, so when we're talking about 68.2% are classed as active of adults, does this mean that is that figure then drawn more from perhaps more affluent areas than otherwise?
So there is, I mean, generally there is a correlation with deprivation. So generally we find that those that are in wealthier areas that have more funding and resources do take up physical activity offers more. Particularly those kind of more formal kind of scheduled offers, so participating in classes. Again, that came up through the educational attainment work, that we do have this gap between those families that do uptake on those offers and those families that uptake on those offers in, you know, that kind of thinking about places such as some of the cricket clubs and the University at Bath. There is a difference in who takes up those offers, and that's one thing that we're really wanting to address through that work. So yes, there is a difference in sporting capital that different families have across veins. That was one of our findings from the educational attainment work, and something that our physical activity strategy will, that will absolutely be a kind of key principle or kind of informing the strategy and a key priority to tackle.
Because obviously it's all very well having the information, but it's the so what do we do about that, isn't it?
Absolutely, and that's where we're in the process of having discussions about how we do that. And part of that, again, is understanding the barriers. So what are the barriers to people kind of accessing and using those offers? Yeah.
Thank you, Amy, and thank you, Alison, for your Cabinet members' update. Oh, I'm sorry, Paul May, who's not on our panel.
I'm sorry, Chair, I'm doing my normal trick of pushing in. Just really, I'm going to report to the next meeting about a youth trailblazer that WECA are doing, which is picking up some of the...
Sorry, Paul, can you speak up a bit? Because you've got to, you're up against scaffolding, I think.
At the next meeting, the children's meeting, I'm going to be reporting about a youth trailblazer that WECA are funding, and that's directly related to some of these issues around NEETs, but also about access into facilities around the area. So it's going to focus on the Chew Valley area and also the difficult parts of Bath, where transport is a real issue for young people. So it won't pick up the children, but it will pick up youth. So it's, I'll be reporting on that at the next meeting, Chair.
Thank you very much, Councillor May. Okay, we move on now to the next item, which is the ICB update from Baines and... Sorry, I had already just said that I'll bring them in before the item, if that's okay. Yes? Sorry, Laura.
That's okay. Thank you, Chair. I'll assume that the report is read, but if I may, I'll just pull out some of the key headlines. So there's a brief update on the future of the NHS reforms. So a reminder to the panel, in March of this year, Government announced that NHSE would be abolished and then subsequently clarified that it would be combined into the Department of Health and Social Care. At the same time, alongside this, integrated care boards were directed to reduce overall running costs by 50%. A model blueprint for ICBs was shared in May, and recent guidance indicates to fulfil the function sustainably and effectively, ICBs are going to need to work across larger footprints. So as a result of this, and as it says in the report, the Baines, Swindon and Wiltshire ICB is currently exploring arrangements with Dorset and Somerset to see if we can have plans to cluster together to be able to respond to that ICB blueprint and a sustainable model. Now, these proposals are obviously an early stage. There's a lot to work through, so no decisions have been made. But I think hopefully that answers some of the questions that were raised in the last meeting. And then moving on, there's an update on integrated community-based care. More fuller update will be provided at our next meeting when HCRG can join us. But again, just some headlines. As we know, HCRG is our new lead provider of developing and leading a new partnership with NHS providers, our acutes, primary care, local authorities and the voluntary sector to transform our care and support and to do seamless integrated care across our population. This responds to the government 3 shifts. So if we think about the direction of travel nationally, so moving from hospital to community, sickness to prevention and driving digital innovation. So in the report, we've clarified that there were a total of 1,950 colleagues that transferred to HCRG on the 1st of April. The 100-day plan is obviously in full effect to ensure the safe landing of those services. There is a BSW community delivery group that oversees all of this, and clearly all partners are represented on that, including local authorities. And then finally, in the report, we set out that HCRG have outlined some methodology on the person-centred approach to how they will look at transformation. There are 9 transformation priorities, just to remind you, that we were looking for in our shared commissioning intentions. And the approach that HCRG are doing is the 4 Ds, if you like. So discover, define, design, and then deliver. So this enables all service users to be at the heart of any future decision-making and make sure that they are as well at the heart of any co-design and co-delivery. So at the moment, all of those transformation priorities we would say are in the discover phase. The next phase, define, will include some level of engagement, and that will be throughout the summer and actually starting now in June throughout to September. So HCRG will provide more of an update when they can join us at the next meeting, but hopefully that is helpful for members on the panel to know. And then finally, if I may, Chair, just a couple of updates around vaccines. Firstly, the uptake of the COVID-19 booster vaccine, and again, you'll see there that we're targeting specific groups of the local population. I know we've had questions around, is the intention to generate herd immunity? It's not. It's to ensure that those most susceptible are adequately protected. And when you look at the figures, approximately 60% of eligible people in Bath and North East Somerset have had the booster vaccine, slightly above both the respective regional and national averages of 58% and 48%. And then on the MMR vaccination in under 5s, I think it's fair to say the vast majority of families with young children have been protected. The latest figures show more than 96% of under 5s in the local area have had at least 1 vaccine. So again, nationally, the figure stands at just over 92% and the South West 94.8%. There is a short update on the publication of the 10-year plan, which simply says that it's been delayed. So I haven't really got any more information on that, Chair. Thank you.
Thank you, Laura. So do we have any questions? I've got Liz first.
Thank you, Laura. I'm going to go back to the new ICB plan, which is going to happen fairly soon, I believe. I know we have to do this. We have to cluster into a larger group. But I'm just wondering why, I can understand Somerset, but I am not really clear as to why Dorset, and what are the future possibilities of us clustering with nearer neighbours such as Gloucester and Bristol. And my second question is, and I know it's still in the planning phase, but what will happen to Baines within this very large cluster? I mean, what power are we going to have? Will we be subsumed into this much larger entity? And what implications will it have for staffing? Will there be fewer staff involved? So it's looking at what power we have within this larger group and what implications there are for staffing. Thanks.
Thank you, Councillor Hardman, for those questions and also for acknowledging, obviously, it is a directive, as you rightly say. There was a requirement to look at those clustering arrangements and to consider different options. That was done on the South West regional footprint. So, indeed, options to look at, Bristol, North Somerset, South Gloss and Gloucester were also looked at. In BSW, the patient flow data is very strong and shows very clearly that actually clustering alongside Somerset and Dorset makes a lot of sense. There are other benefits as well around strategic commissioning hubs that exist across Somerset and Dorset. So the arrangements clearly make sense from a health and social care delivery point of view. And all options, I should say, were looked at for all ICBs within the South West. In terms of what will happen to Baines, to provide reassurance, both through the national guidance that's coming through, the blueprint model, and indeed those early conversations, the importance of place is absolutely recognised. So we see that that is going to be a strength that needs to be looked at moving forward. Obviously, I can't say specifically what that will look like and what those configurations will be or what arrangements will be and on what place-based boundaries, but certainly everyone has a commitment to delivering through place and to maintaining the autonomy around place. National guidance tells us that we need to look at integrated neighbourhood teams. So if anything, as we know, alongside the care model of moving more into the community, the role of place and working in partnership becomes more important. So they're the sorts of things that we need to work through. Sorry, I can't provide further reassurance at this time, but hopefully that helps a bit. And then in terms of implications for staffing, yes, that is very real. The 50% reductions, of course, will have significant implications. So staff at the moment, clearly we are working through that with them around what sort of national schemes may be mandated or indeed what local schemes we need to look at by way of voluntary redundancy and redundancies.
Thank you very much. And maybe you can bring back to us at another date the impact this 50% cut in staffing will have on our services. Okay, thank you.
Thank you. Paul and then David.
Thank you, Chair. We can go all the way back to the times of Emperor Nero to read about the fact that when people haven't got the faintest idea about how they're going to address real priorities, they start a reorganisation. So reorganisations rarely deliver what is judged or needed, and they just divert attention from services and problems. So what are the parameters that in this, and I know it's not you who've asked for this reorganisation, it's been imposed upon you, what are the parameters that you are looking for to judge whether there is any success or any improvement from any single parameter that we're going to have from this reorganisation? Or is it, yet again, just another waste of money and diversion away from services?
Have fun with that question.
Yes, indeed. How to start? I think I understand the passion behind the question and the frustration. From our perspective, again, to provide reassurance, yes, in times of restructuring, sometimes that can divert attention. But I have to say that the staff in the ICB and indeed the partners that we're working with remain deeply committed. We're all here and we turn up every day because it's about delivering for our service users and our communities, and I have not seen that change despite it being several months now. So hopefully that provides a bit of reassurance. In terms of the parameters that we've been given to work with, there is this ICB blueprint model. There is clarity around some things, so some functions, so very much that the integrated care boards will be here to stay. They are the strategic commissioners. They should be working jointly and in partnership. They should be promoting place-based relationships, looking at integrated, seamless, joined-up care. Those 3 national shifts that I spoke about being the priority, and absolutely integrated neighbourhood working. In other areas, I have to say, there is less clarity. So what functions will be happening at ICB level, what might need to happen at the cluster level, and what might need to happen at the regional level. But absolutely that every function needs a home. Absolutely that there will be role clarity and accountability is paramount. So that's why, obviously, we need to work some of that through. The other parameter is, of course, financial. So there are expectations and requirements about how we need to make sure that we fit certain parameters financially as well. And that's part of the sustainability of organisations moving forward. So they're the parameters that we're working with at this moment in time.
So the real answer to that is it's all about a cost-cutting measure and nothing to do with service provision. Everything else is just government.
I'm not sure Laura can possibly comment.
Yeah, I'm not sure that's a question for me, but we stay true to our true north of the service user and making sure that we deliver the joined-up services and the quality services in whatever parameters we're given.
So we do look forward to a report with detailed analysis about any improvement, if any, that we get.
Thank you. So next questions are from David and then Leslie.
Thank you, Chair. Laura, with the reorganisation or expansion of the ICB down to Dorset, etc., how does that affect patients at the very north end of the ICB in Chew Magnan and Throbwell, etc., whose GPs will commonly refer to Bristol or can refer to Bristol? Because you're talking about patient flows, you're now talking about a larger lump of organisation. Are those flows going to be restricted? That's my first question.
So I think at the moment what we know is that we've got a strong case based on those patient flows for the cluster that we're looking at. In terms of how services will be delivered within that clustering arrangement, again, place-based business units is still something that we are looking very strongly at. Of course, here in BSW, we have that integrated community-based care for our community services already. Of course, we have other things that are commissioned already. So we are looking, together with our counterparts in Somerset and Dorset, at functions to understand what can be delivered effectively, jointly together, and what still needs that local lens and local dimension. So at the moment, we don't have any further detail on implications for any of those patient flows. Obviously, what we're trying to do is maintain safe and effective delivery of services and make sure that we keep that joined up delivery of services, and in particular, transform through integrated neighbourhood teams, which is a requirement on all ICBs nationally moving forward.
Thank you. Yeah, I understand that. I guess my concern might be, for instance, if you're referred, say, into Bristol for a cardiac procedure, an elective kind of cardiac procedure, where you're going to one of the largest and best services in the country. If that is stopped, you're actually not going to any tertiary hospital within the ICB because there isn't one. Or the expanded ICB doesn't have one.
Yeah, sorry, I understand the question now. Those patient flows to those centres of excellence regionally, obviously we're looking to still maintain those. So that's something that we need to look at. As I was saying, there'll be some things that still need to function regionally and think about how we make that provision and make sure that we have those referrals. Some things that need to happen at cluster and some things that we need to think about on a more local level.
Thank you. I mean, I guess we'll hear about that in due course, will we? Thank you. Unrelated to cuts in ICB running costs, etc., but last month NHS England instructed ICBs to significantly slow down referrals for routine elective care, didn't they?
I think, if I may, I'll take that question away and come back. Our elective recovery plan is in place, and I think it might be helpful just to explain that more broadly in the round to give some context around that. I can include an update in the next report, if that would be okay.
Okay, that's fine. If you could please include how, because this was in the Health Service Journal, that it was sent around from NHS England, and the aim is to significantly reduce year-on-year growth in referrals with the goal of nearly eliminating it. Well, clearly that's not a needs-driven thing, is it? So it's financial rather than clinically driven, which will result in further restrictions to access to care, potentially increasing waits or slowing the reduction in waiting list cuts coming down. So if we could hear about that next time around, that would be great. Thank you.
Thank you. Are you going to come back with a response then later?
Yeah, if I may, I'll include an update in my next report. I can understand the concerns. If I may, sometimes things that are reported through the HSA are not always factually accurate, and there is broader context. So I think if I bring the BSW plans, but I can absolutely understand the concerns given the level of reporting. Understand that.
Thank you, Laura. Right, next on my list is Leslie.
Thank you for the report, Laura. I wanted to ask first of all about the ICB reform. I think, Paul's point is quite interesting about Nero. I'm not too sure that there was a National Health Service operating in Rome or even Italy in those days. I'll say no more on that. So what are the anticipated benefits and risks of clustering us with Somerset and Dorset? And it's already been pointed out how large this area is going to be. How will local accountability and responsiveness be maintained in this larger ICB organisation? And what mechanisms are in place to ensure transparency and public engagement during this transition? Thank you.
Thank you for those questions. I think it's fair to say I won't have all the answers. I think nobody does to all of those questions, but they're absolutely spot on and the pertinent ones to ask, and clearly the ones that we've got front and centre as we go through this process. So in terms of the anticipated benefits, I think I've outlined that some of those were looked at when we were looking at the potential clustering arrangements. Clearly that needs to be looked at a bit more. In terms of the risks, I think that's well understood, as has been articulated today, around the nature of a larger footprint and making sure that we don't lose that local lens and autonomy. In terms of local accountability and responsiveness and how that will be maintained, ICBs will still be required, obviously, to have their governance structures, including a board, a chief executive, a chair and an executive team, and to be having those appropriate governance arrangements with partners, as we do now. And those arrangements continue until an alternative replaces those, if and when that happens in the future. So that local accountability will still be there in whatever form that might take. In terms of public transparency, I think it's fair to say that given the pace at which these changes have been directed, clearly how this is being able to be communicated from an ICB perspective, we've tried to share every bit of information that we have as soon as we have it. Certainly bearing in mind our staff, but also our service users, and we will maintain that commitment to do so. But in terms of how much input there will be around designing the future state, obviously that's unknown to us at this moment in time. because that's not wholly within our gift. There are certain parameters, as I say, that we work with. So I hope that helps a bit, but all of those questions I understand we need to be able to answer more fully in due course as that information becomes more apparent.
Thanks for that, Laura. Just to go on, I mean, I recognise you've got a really difficult job here. So will there be shared roles between the different organisations within the new cluster? What are the early findings from the Discover phase of the 9 transformation projects? And what safeguards are in place to ensure continuity of care during the transformation? Thank you.
Thank you for those questions. In terms of shared roles relative to the ICB reforms, it's too soon to say yet. We're not at the stage where we've got organisational structural design. But of course, that would be something that we would look at. In terms of the integrated community-based care programme and the early findings on the 9 transformation priorities, I suggest that's something that we ask HCRG to give us a flavour of when they present to us next time. And in terms of what is in place to ensure continuity of care, clearly at the moment we continue with the integrated community-based care programme and working in partnership, and that has safely landed, and there is a 100-day plan in place, and we continue to work on that. We're not quite at the 100 days yet, and those partnership arrangements will continue to be maintained. Remember, the integrated community-based care programme itself actually was commissioned across 2 ICBs and 3 unitary authorities, including actually Somerset ICB were also part of that. So that will continue, and we'll have a further update when HCRG come next time.
Thank you. And on the vaccination uptake, I think, again, you know, we've done really well in Baines, which is obviously something we need to note. But are there any identified gaps in vaccine coverage among specific communities or age groups? And what should we be doing to raise more awareness on that? And just on the 10-year plan, what interim measures are being taken to align local services with anticipated national priorities? Thank you.
Thank you. On the vaccine coverage, we have had a number of targeted, focused efforts into specific communities or population cohorts, including those with learning disability and or autism. But I will ask our vaccine team if they could give us a little bit more information around that, and whether there are any gaps or if there is anything that indeed this panel or others might be able to do. So I'll take that one away. Sorry, in terms of your last question, I think it was asking me around how do we make sure that the emerging 10-year plan aligns with our local commissioning intentions and ambition? Is that the spirit of the question? Yeah. So I think, as I was just covering in my report earlier, we're very confident that the emerging national 10-year plan focuses on those 3 headline government shifts. And as we know, we built that into our commissioning intentions quite deliberately on the integrated community-based care programme. I would say that everything we're hearing at the moment has got a focus on those neighbourhood teams. So I think really it's about the point of delivery. To your point earlier, Chair, the so what bit is going to be that point of delivery. And that will be those integrated neighbourhoods. And of course, that's going to require all organisations working together. So in particular, local authorities, but absolutely with our BCSE community, our acute primary care, to make sure that we're delivering closest to the point of where need arises.
Okay. Thank you, Laura. I have a couple of questions. I did have 3, but Leslie stole my last one. And one is, so we added our voice to the concerns that were raised about awarding HCRG the contract. So we haven't heard back from the Secretary of State. So my first question is, have you?
No, we still have not heard anything, Chair.
Okay. And then the second question, which is related to that, obviously the HCRG contract is awarded to cover BSW. So would the intention then, with a bigger, much wider ICB, would then that part of the system then have to, sort of put out a tendering bid? Would they have to sort of work out a way of commissioning services, or would it be that the HCRG would be expected just to sort of pick it all up? How would that work?
So at this moment in time, we haven't looked at the opportunities for any future joint commissioning across the cluster. So at this moment in time, the Baines, Swindon and Wiltshire Integrated Community-Based Care Programme is our focus. So even within the clustering arrangement, having that as our business unit, if I can put it that way, as a commissioning arrangement, that would be maintained. Now, obviously, over time, there may be other commissioning opportunities that we need to look at alongside Dorset and Somerset, and indeed they'll have their own commissioning arrangements at this moment in time. So we need to look at all of that together. But of course, none of those commissioning arrangements happen in isolation. Many of those are aligned predominantly with local authorities, but sometimes with other partner organisations as well. So we need to work all of that through, but there's no intention at this moment in time to be looking to grow that, to have full coverage of the cluster. It doesn't work that way. We need to look at the commissioning arrangements that each individual ICB has got at the moment and understand what the needs of the population are, and then act accordingly following due process. That still stands, whatever those clustering arrangements are.
I did have a sort of one extra question then, which is, forgive me if you've already said this, but what is the time frame for that, for the firmed up cluster arrangement?
So there's no specific timeline for a firmed up cluster arrangement. Our best understanding at this moment in time is that the intention to release cost efficiency needs to be done by the end of Q3. So that means that ICBs need to be demonstrating that they're reducing their running costs by that time, which is why the pace of those clustering arrangements. Those clustering arrangements would be coming into effect from what we understand 1st of April of next year, and of course then any formal arrangements where it more formalises that would have to happen in due course, because that may require some sort of legislation or not, as the case may be. So I think the immediate timescales that we're all working to is end of Q3 in terms of understanding what we will need to support that clustering arrangement moving forward, so that they can move forward from the 1st of April 2026.
Thank you, Lauren. I know that you, in all of your updates, you keep us up to date with what's happening with the cluster arrangements. Thank you. I'm not seeing any more questions, so I'm going to move on to the next item, which is the respite services update. And what I will do is I'll ask our speaker, so Wendy, if you wanted to speak now. My apologies if you were outside and didn't realise that you could have come in.
My name's Wendy Lucas, and I'm the mother of a special needs adult that currently uses Newton House Respite Facility. And today is the 4th time that I and the other parents have sat before this panel to speak about the impact that the closure of Newton House Respite Facility has on the families that rely on it. We, as families, have spent the weeks since the last panel meeting working with the social work team and commissioning officers to identify a way forward that supports the present users of Newton House and takes into account the needs of users of the future. Ironically, we've only been able to attend meetings and participate in and support this process because on the days of the meetings, our young people have been enjoying their respite from us at Newton House. Much has been shared, much has been learned, and the process has gone some way to mend fences and rebuild the trust that was shattered last Christmas. However, what has become evident is that communication, a subject which was commented on by the recent Care Quality Commission report, within and between council departments involved in the subject of respite and social care still has major issues. This will affect the good work that's been done and the fragile foundations of the new relationships between parents and council. Just last week, prospective families were still being told that Newton House was closed to referrals and they would have to accept placements out of area, i.e. the other side of Bristol, or their social worker would support them with nothing further and end involvement in their cases. The email reads very much like, you take what we offer or we won't help you at all. Another family have been told that they must move from Newton House to the same out-of-area respite facility in Gloucester. This is clearly unacceptable and undermines the figures that will be presented to this panel by Social Care in that report. And this is a big cause for concern and unease, as the strategy for moving forward is built upon these figures. We as parents are realists. We know that our needs must be balanced against budgets, value for money and many competing priorities. We know that compromises must be made in order to move forward. We have been and continue to make them every day. However, we've always maintained that we represent great value for money. All we ask from you is to balance what we require against that. We want the statutory respite we're entitled to. If we fall or can no longer cope because our respite needs are not met, the impact to council budgets will be far greater than the cost of meeting our needs in the first place. Therefore, I ask this panel to keep this subject firmly on your agenda until a suitable long-term solution is implemented. I also call on this panel to push for improved communication within the council offices to ensure that families are given correct respite information when being signposted to services. Families can't use what they don't know about, and facilities like Newton House are then cancelled and closed due to poor uptake. It's an unfair perpetuating cycle that needs to be addressed. Thank you for your time.
Thank you, Wendy. Would you be okay with answering some questions? Yes.
Many thanks, Wendy, for coming again to this meeting and for updating us. I believe you have seen the report that will be presented to us fairly shortly, and there are major issues that obviously we will be asking questions about. And one of them, if I can just add a bit of detail to this, is that we are told that there is a 40% under occupancy of Newton House. And so therefore one of the options of keeping it open is being looked at very closely because it could close. So the first question I'd like to ask you is, you're stating, and we will obviously ask this question later on after you've spoken, is that families are being turned away, that they are told that there isn't any space at Newton House and that it's going to close?
Yes, families have been told that as recently as the 20th of May. I have copies of an email that was sent to a family who are desperately looking for respite, more than meet the legal criteria to have that respite. What they're being offered is a facility the other side of Bristol into Gloucester, a 2-hour drive away, which is completely unacceptable when Newton House is located in Bath.
Many thanks for that, and obviously we will pursue that when we discuss the report that is before us. The second question I want to ask you is, and I believe you have been consulted about this, there are 3 options for respite care, the future of respite care, and I believe that you are in favour of option 1 followed by option 3. Would you like to confirm this?
So again, you know, as parents, we're not silly. We've got a great deal of experience of looking after children and adults with special needs. We know in the current climate, budgets have to be balanced. There are increasing costs all the time. It's all probably been brought to a head by the increase in national insurance contributions and the latest hike in minimum wage. People that provide the respite care have to cover their costs, and that's expensive. The options that were presented is obviously there is a timeline, a very tight timeline. We realise that contracts must go out to test the market, that we cannot hang on to Newton House forever. But it has to be hung on to until that process has been worked through. We cannot have a gap in services. You know, we cannot survive as families with a protracted gap where we don't have access to respite. So the obvious solution is to keep Newton House open for, or hopefully encourage Dimensions to keep it open for as long as the process of testing the market with the new contract lasts. And then obviously then, with whichever outcome of that market test is a new facility. I think, you know, we've all accepted that for the council to run that kind of service in-house just isn't an option. The cost of buildings before you even staff it, it just wouldn't work. It's got to be a commercial provider, and that's what we've accepted. But for us, the major issue is the timeline. The existing provision has got to stay open whilst that competitive tender exercise goes on. And if at the end of that competitive tender exercise there is a new company, not Dimensions, then there is a whole transition period that would have to be managed effectively, because these are not the type of young adults you can simply pick up on a Friday and drop somewhere new on a Monday. There are behavioural issues that will take time to be addressed to get these young adults used to any new provider. But for all we know, you could test the market next October, and actually Dimensions and Newton House could still, if they choose to tender, end up being the preferred contractor, because with the experience that they've got, they know what's required. So again, we might be in a situation come next October where it's a new contract with Dimensions and Newton House. Who knows? But we just need to know as families that that continuity of service will remain throughout this whole process, and that if there is a changeover next October, that that's going to be managed. We're already in June. It's not a long time scale, just over a year to do all of this. I've highlighted that, you know, we've gone a long way to rebuild trust in a process that for us was shattered last Christmas. It is ironic that we've only been able as parents to participate in that because our children are at Newton House while we do it. For us, we just want that surety that we will have a continued service within Baines, and we would like to see this continual pushing of out-of-area respite options north of Bristol stopped. It's not fair on the families, and the families are finding it actually quite distrustful when they're being told that Newton House is not open to referrals, and yet the reason that we're in this mess is because Newton House was only running at 60% capacity, and it's one of the things we've highlighted from the very beginning is why is it only running at 60% capacity when families are being told there is no room?
Many thanks, Wendy. Thank you.
David.
Thank you. We've been previously told that there were families who needed support and were not being contacted, and so the estimates of demand for Newton House was not accurate, potentially. Do you know if all the families who might need support that you're aware of now been contacted?
So obviously Suzanne and the council officers have produced a set of figures from the investigations that they have done. Those investigations are the statutory assessments. We still have doubts as parents that all the statutory assessments are being done. Indeed, I've got people to the right of me who currently use Newton House who still haven't had their statutory reassessment done. We have to trust those figures, and at the moment we don't. I am picking up examples. I have a new one this morning as I say, of the family that were told they would have to be pulled from Newton House and sent to respite the other side of Bristol. So our confidence in those figures is still not 100% that families are being identified and signposted to the facilities that they need to use. And I don't know whether that is a communication problem, I don't know whether that is a cost problem, because we know, you know, the spaces at Newton House are expensive. We have expensive children. Their packages are huge, but they're not going away. And neither is that requirement, and packages for full-time residential care, which is where we will be going if we do not get the respite that we need as families, are even more expensive, if you've even got them.
Leslie.
Thank you, Wendy, and to all of you for coming along again in your diligence with this particular issue. Can I ask, do you think that families and individuals are being given real choice and control over respite care that's available?
I think from the tone of the email that I've got, the answer to that is no, because the emails are written in such a way that basically the families are being told, you take what we're suggesting, or actually we're going to back off. I've actually got an email where a social worker says to a family, you either go forward with the respite in Gloucester, or actually we'll close your case. We won't look at anything else for you. So the family feels very pressured that if they've literally got to the night before of dropping their daughter off at this place in Gloucester, because they felt that if they didn't go along with it, they wouldn't get anything at all. And they can't cope with nothing at all. That's the difficulty. And again, I don't know whether it's because it's a miscommunication still within the council between commissioning officers, social workers. Do social workers on the ground really know what's available, who they should be talking to? I don't know. I'm not an expert in that. I've just seen the emails that, you know, these families are getting. And to me, as a parent who's come up against this brick wall as well, you do feel very much, if you don't go along with what your social workers are suggesting, you won't get offered an alternative. They literally will step back and go, well, we've done our bit, you know, we've given you a choice, you've turned it down. So that's the end of the discussion now.
Sorry, Leslie, did you have more questions? Okay. Thank you, Wendy, and I will allow the officers to respond when it comes to the actual report. I just wanted to ask one question of my own. You spoke of an email that you'd received saying that the provision was going to be shut and therefore there would be no new care packages being offered at Newton House. Was that email from the council or was that from Dimensions?
No, that was from a social worker responsible for the family in question. That was the social worker's response to the family, that Newton House was not accepting referrals.
Thank you. That's been very helpful. Okay. We're now going to talk about the report on respite services. So what... Sorry, Wendy, would you mind turning your microphone off? Thank you very much. So I'm going to ask Alison if she would like to introduce the item, and then I hope that officers will be able to then address all the concerns that you've highlighted. Alison.
Okay, thank you, and thank you, Wendy, for speaking once again. It's always really helpful to hear your perspective. You raised some issues that I wasn't aware of, these cases that you've raised, so all I can do is defer to Suzanne and her team to investigate those, and Suzanne may want to say something in response. But I just want to reiterate that respite care is an important and essential element of carer support, and it's provided locally through day services, through respite within the home or the community, that's sometimes called relief care, and through residential respite, either through the shared lives scheme we have or through respite accommodation, which includes Newton House for the people with the highest levels of needs, people with really complex needs. And I think when the social workers do the assessments, they try to match the needs of the individual with the range of accommodation we have to ensure that we're providing the right level of support for an individual's needs. And that should be a discussion and a dialogue to ensure that we get to the right point with that. And I hope that that is what happens in the vast majority of cases. I'd like it to be what happens in all cases. So hopefully we will get to that point. I mean, sometimes there will be differences of opinion, but I'm sure we have processes internally which will look at that and try to ensure that we are coming up with a fair offer that meets needs. Anyway, the paper that we're looking at this morning focuses particularly on the need for residential respite for people with the most complex needs. And that is as a result of the discussions, the ongoing discussions we've been having with Dimensions about the future of Newton House. The paper looks at the outputs from the working group, which you've referred to, which Suzanne has been chairing, and where adult social care staff have been working with carers of families who use Newton House. And it's been really important to hear what your needs are. And just to say as well that we continue to work closely with Dimensions, and Dimensions is the organisation that owns Newton House and operates Newton House. So we don't have complete control over the outcome of this, but we do work closely with Dimensions, and again we are hoping to reach a negotiated way forward which works for all parties, and I'm sure everybody is committed to doing that. So I'm going to hand over now to the officers to say a bit more.
Thank you. I wanted to thank Derek, Wendy, Mike and Richard, because they were the four main people that supported us in the paper that Natalia is just about to present. I am aware of one case which Wendy was good enough to email the detail to me, and we are dealing with that case. I've been away for 3 days, so I need to just check. But as far as I know, that's been agreed for Newton House. The other case you said came in this morning, so hopefully you'll send me that detail. So that's two cases that I'm now aware of. Basically, it's fair to say from a social worker's point of view, because we hadn't agreement, and Natalia will talk a bit more about it in a minute, had formed an agreement from Dimensions, we were looking elsewhere, because as far as we were concerned, up to the last time we met, that Dimensions hadn't agreed an extension to the contract. So therefore, our social workers were continuing to look outside of area, and Natalia will update a bit more on that. So from the point, I understand what Wendy says about the disconnect between commissioning and social work. It wasn't a disconnect, it was just the fact that we didn't have the agreement at that stage, so we were looking elsewhere, and that was the issue that we've now resolved, which Natalia will talk about in a moment. So I'm going to hand over to Natalia and to Claire Hannon as well, who is the commissioning lead for Newton House. So Natalia.
Thank you, Suzanne. I think half of the report Wendy very eloquently presented already, so thank you. I'll start with them absolutely, and that's how it should be. I just wanted to say I absolutely echo what Wendy said. There was a lot shared and learned, and we've made progress together, so big thank you for everybody who contributed. So I'll talk about the needs analysis first. This is the first time we have looked at which families and which individuals are using respite in veins across all ages. And that was a direct response to learning from where we were last autumn. It is a complicated picture. And the main point I want to make, this work is not going to stop, because everything we've learned, specifically around short breaks and respite, is it's got to be flexible, it's got to be available, and it's got to respond to changes in the individual's needs, but as importantly, in the needs of their families and their households, because respite primarily is the support line for the families. And that's the commitment we're making. We're not closing the needs analysis, we're not closing the review and the learning, who needs it and what does it look like. We haven't fully completed that piece of work because it's the whole population. We have looked a lot at children and young people and their families and what their plans are 5-10 years. We need to write all of that up. We have looked at adults, in particular in response to complex needs and building-based respite, and we're continuing to look at older adults of BAMES and their families and which services and types of support they're using for respite. It remains our plan to write all of that up into a single report because it's in an all-age review. But we're looking at later in the autumn because that work needs to be done properly. It's large population groups, large services. And we're talking to providers as well because their care models, some of their restraints and opportunities in the business and support they're offering are also changing with times, and we want to include because it's important. We have presented the high-level overview of the needs analysis in the report, but I wanted to say it's a life continuing piece of work, and that's in response to the learning we have all had. The second part of the report is about the options analysis. We did look at 3 options, specifically for accommodation-based respite, similar to like Newton House, because this is our current local service. Our commitment is firm. We want a local building-based respite service for adults with complex needs. That means it's not for everybody. It is for adults with complex needs following an assessment of statutory need and a professional determination by the social worker and their team that that is the best way to meet the needs of that family and that individual. The 3 options we've looked at, one is to have Newton House available for longer or a similar service. That has always been on the table. The second option was for the council, for us to consider, can we be both a landlord and a provider of a similar service? What opportunities do we have? Are they imminent? Are they longer term? What would that look like and how much that would cost and what would it take? And the third option, always because we are commissioning organisation, can we commission a new complex needs building-based service externally from the market? With the working group, we have looked at those options. You see the preferred option, which is option 1, to keep Newton House open and available as is for the rest of that contract, followed by a market test and recommissioning, which is what the law requires us to do, and we are operating for the past 3 or 4 months under the new procurement regime, and that is continuing to be the case. Alongside this work, Claire led continuous conversations with Dimensions, both as a provider and a landlord. We have very good relationships with them as an organisation. They have been learning alongside us, and we have concluded the final stage of can we make option 1 available and real a week ago. So we met with Dimensions Regional Director a week ago on Friday morning. Absolutely everything in this report they are aware of and support, and what I can update the panel and members of the public on is we have formally agreed with Dimensions that they will continue running Newton House for the rest of the current contract they've got with the council, which would take us from now to the end of September 2026. The moment that was a formal agreement, because I'm the lead commissioner, when I'm speaking to operations director, it's a decision, and we have drafted a letter and we're sending a letter to basically make sure that agreement is in writing. The moment that meeting has happened, that means we can open Newton for relevant referrals, new referrals, and that was the first call we had to operational teams. We spoke to the social worker who was supporting one family on the new referral of complex needs for Newton House. So in terms of communication to the teams, that has happened on that day. And what we've done early last week is we've updated the brokerage team, because all of the new agreed referrals would go from social care teams to brokerage. And the provider is giving the same message to families, because they don't deal with self-referrals. Of course, they'll talk to people and promote the service, but it has to be following the assessment and review process. And in most cases, it does, but absolutely. So that is the current position. We've got a formal agreement with dimensions, the service under the current contract, so we're utilising the rest of the contract, is open and will be available until the end of September 26, and the new referrals for people with complex needs are being received and will continue, because we now have a longer period of time. But as Suzanne said earlier, without the provider final agreement, that was not an option, because everybody's got to be in agreement. The second point of learning, and I think Dimensions would recognise that as well, as part of this work, they had to think differently how to promote service in veins to other areas and how to build new and different interest in the service. Again, they're not going to stop doing that. They've got some very positive initial responses from Gloucester, from other, sorry? South Gloss and Somerset. They're pursuing those conversations, but also what helped them is it's our needs analysis. They now know for the next year and a half what we need in Baines as we know today, and that situation is changing, which means they know what else they need to generate outside of Baines. They're committed to the service, they're fully aware about the planned procurement, both of respite services but also of care and support for adults with learning disability, autism and neurodiversity. And we're also learning from Dimensions as a provider, but also from regional and national sharing of commissioning intelligence and market experience. It's very rare that respite services are self-sufficient on their own. They're usually commissioned with a larger portfolio of services, maybe supported living, maybe residential care, exactly because of the nature. It's got to be available, therefore it's got to be fully paid for, and then responsive to fluctuations in demand. So a lot of learning, a lot of sharing. We are in a different place, but the work is not going to stop, and there is much more to do.
Thank you. So, questions. Liz, then David, then Kevin.
Natalia, thank you very much for your update. I still am not very clear about the 40% under occupancy at Newton House. Are you saying this was due to dimensions and that you had to look again at the contract and that they are now going to start accepting more referrals? We've also heard that it was the social workers that didn't refer young people for respite care to Newton House, and we're looking elsewhere, and you've explained clearly about that. But we're still not very clear, this is my first question, as to what's going to happen in the future. Are you saying that Dimensions, until recently, have not accepted more referrals, and it's down to them, or is it down to the social workers, or now that you've got this new agreement with Dimensions and they are going to operate the contract until October 26, that this is what's going to happen, and to reassure the carers that this is going to happen?
So there are two questions in that question. One around the length of the contract. Yes, Dimensions now have agreed that they can run the service as it is today until the end of September 2026, and that means as of last week they're open for new referrals. So that's a fact. The second point is, looking at all of the information we have got available, and we didn't go further before pandemic, because pandemic reset a lot of things for many families and individuals. I don't think we have ever had 100% use of Newton by Baines residents. There is a difference between what we need and how big the service is. So 60% is not new. What it means is we haven't got a contract for 100%. We're spot purchasing, and we have explained that in April. But the viability of the total service is a combination of what we need for Baines residents and what dimensions as a provider need to generate from outside of Baines, so the totality of the service and the contract is viable. And that's what we've learned. What does it take? If they have more demand or less demand, what is the impact on what we need? Because we have reviewed everybody who is currently using Newton House, and that has been confirmed by social care teams. We do it every year, and there is an allocation of days and nights and hours for those individuals. Dimensions have planned all of that in, and it is 60%. So they're continuing to generate additional interest outside of Baines to have a viable service. We'll continue reviewing the needs and demand analysis, but when we go out to tender, it's that information on which we're going to be saying, this is what we need in Baines. So that's the difference between 60 and 100. It's a mixed model. It's not just for Baines' need.
Thank you for that, Natalia. And thank you for explaining that. It's only a shame that it's not, more for Baines, 100% for Baines. But obviously that may be something that can be discussed in the future when we're looking at the three options, because in your paper, the paper that's been presented by Baines officers, there are three options. The first option, which is the one favoured by the parents, and which is an option that they know about, which is Newton House, it said that because the numbers are expected to decrease, this would not be a favourable option, which would be one that Baines might recommend, because numbers are expected to decrease and Newton House might close. Now, I'd like you to explain that, because what figures are you basing that on? Thank you.
I think you're referring to some of the advantages and disadvantages in the options appraisal in the appendix. As I said earlier, as part of the learning, there are annual reviews, there are changes in circumstances, and families, and I'm not sharing in individual situations because obviously it's not an appropriate thing to do, but there are families who are looking at longer-term different support and care options. So with their agreement, and that work is happening, and it's right so, because it's reflecting the needs and their circumstances. So what we're saying is demand for Newton House and other services, it fluctuates, it goes up and down, and that's why the responsiveness and the flexibility of the service is very important. One thing in the needs analysis, we're continuing to look for and learning, because we need more information, but also a bit more time, is emergency respite. Most of it is planned and booked in advance, whether it's holidays, whether it's regular pattern of long weekends or during the week, but we also use respite services for urgent situations which happened in caring families where they need somebody else to step in or they need to step out. So that work will continue. So I'm expecting the demand to continue to fluctuate. What we know, and it is being planned in for a year ahead. And then every year for people who are, as part of their care plan, have a respite allocation. Again, there is that review and reset, and then the provider and the families directly make the bookings and the arrangement. That process will continue, and that's how respite services are run.
So getting back to these three options, and firstly, when will a decision be made about which option is chosen? I mean, the other two options cost a lot more money. Obviously, that is an important consideration. You're saying the numbers do fluctuate, and we've heard that, some young people who need care are going to other local authorities outside of Baines, but obviously we have this local authority, this respite care place, Newton House, in Baines, which obviously would be more cost effective, which the families know of, and which you yourself have said, the numbers are going to fluctuate. So bearing that in mind, do you have is there a time limit or a time scale as to when one of these three options is going to be chosen?
So we have concluded the options appraisal, and option 1 now is a fact because the service is open. Okay, so we're open for new referrals. We have been for a week, so I take that as this is now the agreed position, it's a fact. Option 3 is not an option. Unless we do it ourselves, we have to go to the market, because that's the procurement law in this country. So there will be a procurement exercise for care and support for adults with disabilities, autism and neurodiversity, and as part of that, we plan to recommission respite, which is building-based.
Thank you, Natalia. I do understand there is an option 3 going out to procurement, and I believe the families have, and Wendy has actually said that they are supportive of this as long as it takes place well before Newton House is planning to close, although it may stay open after September 2026, beginning of October 2026. So I do understand that. But what you're saying is that, and I'm just teasing this out from you because we need to be absolutely clear, you are saying that as of last week, Newton House is taking more referrals, and they're open to taking more referrals. Okay, thank you. I'm sure there may be other questions on Newton House from other councillors, but if I could just ask you about 3.15, which says all currently using the service have had a reassessment or a review. Now, an allegation is being made that hasn't happened, so could you just enlighten us on that?
So that refers to what we spoke about in April, when we were looking at, before the options appraisal, what is the situation. Quite rightly, we have started with families who were already using Newton House, and that was 17 families, and there was a focused piece of work with social care teams. Actually, there was one social care practitioner in the later part of that week, which was coordinating that work, and assessments, reassessments and reviews have happened for those 17 families, and that has been confirmed by the social care managers, and that is how we know, and what we have built into the report to indicate that some of those families are looking at different long-term options, and that work and transition into those alternative options is happening for them, because that's what they've agreed to do and that's what they're eligible for. Some families no longer use Newton House. Actually, before we started, it wasn't 17, so we have definitely looked back for the last 2-3 years to see what was the change in demand and need and the bookings for the service. So that refers specifically to 17, and that the information we've got available.
Thank you. But is there a timeline as to when the decision is going to be made? I assume it has to be made by September 2026. So will the decision regarding which option is going to be chosen for respite care within Baines, is that going to happen by September 2026, or will it happen before then?
It will happen well before, because we are planning to start, because this is part of larger recommissioning and procurement, and we are going to start early conversations with the current providers this autumn, And the reason I'm saying with providers is because it is complex. Most of those services we're going to be recommissioning are accommodation-based, and they're not the council's buildings. So we've been gathering a lot of information for as is. Who are the landlords? Who are the managing agents? Who is delivering care and support to build the picture? And actually the first conversation with the market we had this summer, because we had other market engagement events, and it generated a lot of interest, both from local providers and providers who are not yet delivering care and support in Bain. So in a sense, they're waiting for us, but also similar to the working group we just did around respite, we are planning engagement and conversations with service users and their families who are using other learning disability and autism services, because it's quite a large group and a large portfolio of services we're commissioning at the moment. So the work will start in earnest early in the autumn, and that would inform the design of the support and the procurement timeline.
Thank you. That's it.
Thank you. I hope when you're building the timeline, though, you're taking into account the needs that have been expressed about that the young people need a lot of time to know if there is change. So back to my list. David and then Kevin.
Thank you, Natalia. Could you explain brokerage to me?
So it's a team of commissioners who match care plan requests from social workers with what the providers have available in veins and out of veins. So social workers and the social care practitioners do the assessments and the care planning with the individuals and their families, and they say this is what we're looking for. As commissioners, we make sure that there is a range of care and support available, and the brokerage team bring two of those together and say, if these are the needs and this is what we're looking for, who is currently we have contracts with, and which services would be able to meet what is in the care plan. So they do the matching.
So a client, a person could be referred to one or other service or one or other provider through this arrangement.
If there are different options, they will be looking at the best option, both in terms of the quality, because obviously quality is important, and we've got Care Quality Commission, regulated services or other quality charter marks. They will look at the match to meet the need, and they will look at the value for money, because all of those three are within the statutory duties of the council.
And that includes locality?
Yes, no, absolutely. Our intention is, wherever possible, to meet the needs locally, and that's why we are following for quite a period of time to understand, when we're not able to, what were the reasons. But we also, maybe not for respite, but I think your question maybe is broader, we also do have families, individuals for whom the best choice is for their needs to be met outside of the area, and that is fine, and when that is the case, we will do that as well. So not out of placement, not all out of area arrangements means we couldn't meet them locally. People choose for a variety of reasons to go out of area as well, and we will support that where we can.
Yes, thank you. I mean, because obviously if someone lives in Nebula, Throbwell, and needs respite care, and there's something just over the border in North Somerset, it would be potentially better for them to go there if it was, 2 or 3 miles away, rather than come across quite a distance in the patch. Okay, I understand.
So next on my list is Kevin, then Leslie.
Thank you, Chair. Natalia, two questions I'm trying to clarify in my own mind, bless you. The first one is, can you, again, probably harping back to the question that Liz posed around the timeline, could you be a bit more succinct in saying how much time you are particularly allowing for the transfer, if needed, of young people? So if you're saying, we think it should be 6 months, we think it should be 8 months, whatever, and then what other parts of the timeline you have definitely got to do and how long those will be? So can you just give us what parts you are now going to go down? So the last bit may be, if an alternative provision is required, this is how long we are going to give those young people to transfer, and go working backwards to the other parts that you are now considering, just to clarify the whole of that. The second question is around the idea that if a particular provision closes, such as Newton House, and, for example, there was going to be a costly residential provision, when you come to look at alternatives to Newton House for respite care, how much do you factor in, or is it maybe a number of places, for flexibility? You mentioned about emergency care, so it could be one of the carers is suddenly ill and emergency care is required urgently. So there must be a degree of spare places that you are paying for or needing to pay for. Could you clarify what that currently is and what your thinking is around that and how it's calculated in terms of the spare places and flexibility needed against no places and maybe a residential needed? That's the two simple questions.
Thank you. So I'll try to answer them in turn. So for the first one, transition, because when we go into procurement, unless the process has concluded, nobody knows whether there will be or not a change in provider. So transition planning is built into every procurement. It tends to be longer transition period if accommodation is concerned, because there is more to transfer, and definitely if there is complexity of need. Scale of the service and the staffing teams are another consideration. There isn't a golden rule, but I would say 3 to 4 months for a transition is in most procurement timetables, and longer if that's required. And as commissioners, we decide that before we publish the procurement formally, and it's also something we would ask people who are currently using services, and we also would ask the market, because the market would have a view as well. What would be different in this case, and might give us some flexibility, our ambition is to commission a framework. It's usually a longer-term arrangement, and it's got quality and cost and other parameters sort of laid out at the beginning. Currently, we spot purchase. And what it actually means, if the market is positive and interested in the framework, when we have commissioned it, we will be transferring over every single spot purchasing arrangement into the framework. That is usually done over a longer period of time, because that's best practice. So we're not moving from one contract to another. We're planning to move from a lot of very small individual contracts to a large framework, which is a large contract, just a different word. That should give us some flexibility in how we do it and how long we take to do it. But it absolutely has to be planned. It's got to be safe, both for the people who are using services, for any infrastructure, but as importantly for the workforce, because the TUP regulations are often apply and bring their own requirements with that. So we are looking at 3 to 4 potentially longer months for transitions, and that's the first part of your first question. The second part is, I cannot confirm what is the timeline we're working to, because we start with the market engagement, we talk to people who use services, and then we develop an indicative procurement timeline, and it stays indicative until we've published the tender. We're months away from that. So we know where we were to land. We know what the steps are, because this is not new, this has been done, but it will be new for Baines. Baines never had a framework for services for people with learning disabilities, and that's why I want to start with the team having focused conversations with all of the stakeholder groups and start developing that timeline. And your second question was about... Escape me.
The costings or allowances you're making between them.
So what we know is if we were doing from scratch, we'll be commissioning something smaller than the current site of Newton House. How much smaller? That depends on the model of care we go for. We will do modelling as commissioners, and that's why we spent the last 6 to 9 months speaking to commissioners in other areas who have had similar situations and how they've responded that differently. And we're continuing learning from Dimensions how they're making the service viable for them. Because obviously there are staffing costs, there are costs of running and keeping the building available and in good shape. You absolutely, as you suggested, you build in and pay for flexibility around the not used bookings and nights going up and down, including emergency respite. But what we have also learned, and again, different providers do it differently, is whether the workforce are dedicated to the service and work in this service only and nowhere else, or whether they are moved around. There's got to be a larger staffing pool for the provider to call on. Dimensions do it flexibly. Other providers may be doing it slightly differently, and that's what we're going to be teasing out from our market testing conversations. But I just want to assure the panel we're not the only commissioning team of the local area rethinking what it takes to commission a sustainable, flexible and responsive respite service. And every time I mentioned in the conversation, there is usually a follow-up because everybody is looking at this and we're learning together.
Chair, can I just do a quick follow-up? You mentioned the time frame may be different because you're going to a larger framework, a new framework. So have you built into the current contract, or that you're getting Dimensions to sign up to October 26, flexibility that if you need to take longer because you're moving to this new framework, they will provide that flexibility to keep the provision going for you?
So the Dimensions we're not signing anything because we have a contract with them in place, which will take us to September 26. So they're not really signing anything new. What we're doing in the letter I mentioned is confirming that we can now start receiving new referrals. The flexibility for that transition and what it means for current services, that's the conversation we're going to have with procurement as we start building the framework and the timeline for getting there. So it's absolutely going to be built in, but unless we've done that work and listened to the market and spoke to procurement and did the detail work, I cannot sort of give you the date, but we'll absolutely build that in.
Right, so just to confirm then, because I thought that one of the concerns that the parents had, or the carers had, was certainly around the fact that Newton House wouldn't stop until an alternative, if needed, was there. So are you saying that that sort of conversation will go on with Dimensions to ensure that that provision will be there, and the flexibility given if you suddenly need, depending on the market, a longer time than is possibly October the 26th? Because obviously what we don't need, and the parents and carers don't need, is for it to suddenly stop at the end of September and then there is a huge issue.
No, absolutely. Every planning and transition I've talked about is to make sure that there isn't a gap between service provision. And that's why an early conversation with the procurement team and staying within the rules and standing orders of the Council allows us at an early stage to explore what would that flexibility look like.
Okay, thank you. So on my list I've got Leslie and then David.
Yes, thank you for the report, and I'm pleased to see that some progress has been made with regards to meeting with the families and carers of the service users in Newton House. I did raise a question before, and I note in this report that it talks about an equality impact assessment will be developed, informed by the information generated by the review. However, I'm still concerned that when that letter went out before Christmas last year, where service users were told that it was going to change, that there was no equality impact assessment on that decision. And while this talks about all stages, when are we going to see those equality impact assessments? And similarly with the risk management, I would have thought it made sense to have a look at what the risk is in the first place, because what we're doing, it seems to be a bit derriere about face here. We're doing it back to front, instead of having a look at what the potential risks might be and how we could manage them. So when are we likely to see that? Other questions I've got around how transparent and inclusive is the communication with families? Are their views being taken on board regarding potential changes and future plans? And we know that you know, changing things costs money, but so what's the cost of closing down one contract and then setting up another one? If we've got something that's working well and we understand this does work well, you know, why change it? And then that brings me back to the issues around provision. So if the usage is only 60%, what are the financial implications of that? And what's being done to make sure that potential service users know about it, that that service is there? Because if you've got, or you're in a position where you need this kind of respite care, you do certainly need somebody to tell you what is available. So where do you get that information from? How do you find out that this service is there? It's not the sort of thing that you generally see on the billboards. I'll stop there for the moment, but I may want to come back with one or two others. Thank you.
Thank you, Councillor, for your questions. At Christmas, when the decision was taken, there wasn't a quality impact assessment, and I think I've said that before. Just as a reminder, we buy those beds up from Dimensions. We don't own the full 5 beds. We haven't got a contractual arrangement in that way. So when you talk about the 40% not occupied, we now know as of today that the occupancy is much higher because Dimensions are selling their beds outside of Baines, and they've also used it for a provider that had a fire actually in the accommodation, and some people moved in there for a period of time, so they're using it in different ways. Your point around risk management, we're constantly reviewing the risks. We've got it on our risk register as well, adult social care, because we're very concerned about making sure that those people that need Newton House, which is specifically for residential respite, we have a range of other respite going on as well. Why change now? Why change now? Because, you know, from a contractual point of view and a quality point of view, we're constantly reviewing and improving and evolving. And therefore, not just around respite, as Natalia has said, we've talked about all of our LD services, and some of those LD services will have come back through HCRG subcontract as well. So it's a real opportunity to look at what good looks like. And I've been talking to the families about the next step. how would they help us with developing the new offer, what will look good for families, but also what will look good for the people who use the service, because they also need a voice. I'm not just talking about respite now, I'm talking about people with learning disabilities, so we'll want to be engaging with those. Are we telling people about Newton? Probably not. What we are doing is that if someone has an assessment by a social worker, there'll be a range of choice for that person, and then our brokerage team will go out and procure that on their behalf. Because Newton House wouldn't be for everybody with a learning disability. It will be for people with very complex needs. So it would be unfair, I think, if we went out and advertised it and then people got refused because they didn't have those needs assessed by a social worker. I think that's about all of the questions you asked. Did I miss anything?
I think you got them all. Am I right, Leslie?
Yeah, could I just come back? Because I'm still a bit confused about why there's no equality impact assessment on that original decision and the decisions going forward. And also, if the service is going to be elsewhere, then surely there's going to be a need to travel, so that will have an impact on climate as well. But that hasn't been picked up in the report. And if you note from previous meetings, we have an issue with Fossway House, where the contract there was being finished. That may not happen at all, according to the current providers, but isn't that also an area where there was respite care? So it may be that respite care is provided in different ways for different people, but what happens to those people? And I understand there's one person already who had a child there who is now unwell as a result. And I understand from looking at the information that for people with children and adults who need these very specific services, that the strain is absolutely tremendous, and surely we have a responsibility to be trying to remove that as best we can, rather than making it more difficult. Thank you.
I don't know if there was a question there, just a statement. What I will say is that we will be doing a quality impact assessment for the work we're just about to do. Natalia might want to comment on Fossil House, just to say the work that's going on there. We're tracking young people in transition from year 7, age 14, to see around what their needs will be, so that we have got the right services for them as they come into 18 into adult services.
Thank you. David.
Thank you. If there are a number of people using Newton House, and that at that time it's the 60% of occupancy, so you're up to your full contractual level at the time that Baines is paying for, and then there is another person or family who needs the service. Can those people still access the service, even if you're going above your 60% at that time? Yeah.
For the minutes, yeah, and confirm yes, because that's the importance of the flexibility, because you don't know when you need respite all the time. It's fine when you plan it in for twice or 4 times a year or whatever. There are times of crisis, and that's why in the new procurement, and this has come direct from the families as well, is that you do need that flexibility of crisis intervention. And that's why we've got to work through with the market what that could look like. But I feel that the families could help us shape that as well in the next stages, and that's the importance of the engagement. If they're prepared to, we've used 4 people already, maybe they'll give us another 4.
Alison.
Oh, Alison, sorry.
Can I just add to that? I mean, that is one of the challenges of providing services, that If they're full all the time, then you don't have any flexibility for emergency respite. So I think one of the things that providers do is when they determine their costings, they will build in a contingency that allows them to have some empty space but still be financially viable, and that's what they will be working on, and we'll be working on with them.
Thank you. So I've got a couple of questions. I'm just going to double check that they've not already been answered. So we spoke about transition times. Can I just clarify? What does 40% vacancy look like? You said there are 5 beds. Obviously, not every one of those beds is being used for an entire week. So if you have, I think there was mention of 2 cases coming forward, would they then, what sort of percentage of the vacancy rate would they then take up?
I'm trying to work out your question. Generally, in respite services, you'd never have 100%. Because you've got people coming weekends, some families will have 4 weeks a year, and as Alison has just said, they always build in that cost a bit more as well, so they understand it. What Claire looked at was over the year, how occupied were the beds, and that's what we saw. Those 5 beds were occupied 60% of that year. And that's where we came up with 60%. I'm just checking up there that I got that right. So that's all that means. And one of the things that we think from talking with the families is that we have to have at least 3 dedicated beds, because that would probably give us that close to 100%. But then we need those a respite bed, one or 2. I don't know what that looks like yet. I think we have to scope that out.
So I guess what I'm saying is if you had 2 more cases that you accepted needed the respite, would that make a significant dent in that 40% vacancy?
Yeah, if I can just try and answer that. It depends on what their needs are. Because some people need it just for a day every now and then, some people need more. So it's really hard to determine just on a couple of people, but a couple of people are unlikely to make that much additional demand over a year.
And just picking up the point I think Natalia made about the sort of spot purchase of the care. Presumably then it's down to dimensions to fill some of that additional vacancy. It's not down to the council because they're not all our beds. Okay. All right. And then I think that's probably everything else was broadly answered. Apart from the time frame, just to give some sort of surety, I think, for the parents here. When do you think you would be in a position to be making a decision about whether or not you were going to go to out to tender with a new contract? I know that you've said you'll keep the provision at dimensions until September 2026, but obviously the parents here will want to know and you know, be able to put forward some plans, I think, about when or if they will need to make any alternative, if they'll need to make any sort of alternative plans.
So you can see that we have to have everything done by the end of September next year. So we're working back from that. So we're doing the engagement, like Natalia said, in the autumn. What Natalia suggested is we have to have about at least 3 or 4 months to mobilise. So we have to have the procurement, the award of the contract, at least 4 months before September. That's how we work through. I can't give you definite dates now because we've got to work that through procurement. But that's the average. Now, I think the question that Kevin asked earlier on was an interesting one, was how can you guarantee the families that there isn't going to be a gap? And that's what we've got to work through. Right now, we have a responsibility under the Care Act to offer respite. So we have to stick to our Care Act regulations. So we've got to get this done before September. But it's that question of, is there flexibility with Dimensions to be able to say, okay, we've gone 3 months out, or the family said to us, 4 months isn't enough, you need 6 months, you know, you're working with complex people, would there be flexibility? And we do need to ask Dimensions that, I think so. Kevin.
So do you think some of these questions then might form part of your meeting that I hear is coming in July? Sorry, I don't think you've got your microphone on.
Yeah, sorry. Yeah, we've got a meeting coming up in July, but that's all 17 families. And what we didn't say was that with the 4 representatives who've been working with us, we've been sharing the minutes with all of the families, and then the 4 reps have also been speaking to the families just to keep them updated. And this is the next big meeting with all the families together, because I think there'll be more questions, and there'll be a situation, I think, where other people might want to be involved in some of the work that we're doing, because it is very hard on the 4 people who come into Guildhall every, twice in May, and it's 2 hours a session. It's a lot to ask people to do, and I'm very grateful for that. But it does mean that to get good engagement, you've got to spend time at it, and it might mean that sometimes the process gets slowed down just to make sure we have the families' voices in the middle of this.
Thank you. I'm sure that September's report from the Cabinet member will include an update then on that July meeting.
Yes, Chair. Thank
you. Okay. Obviously, you're more than welcome for the next part of the meeting, which is around the carer strategy, which you might also be interested to hear about. But if you wish to go, that's also fine. But thank you very much for being here. It really is appreciated to hear directly from you. The next item, as I said then, is on the carer strategy, and I believe Councillor Jackson wishes to make a statement.
Assuming I can work out how to make this microphone work, can you hear me? I mean, is it working?
We can hear you, Eleanor.
Right. So this is a statement about the carers strategy update, which I've read very carefully. Thinking about the report which the panel is asked to consider today, I was struck by the fact that we could not possibly know what it was like to care for somebody 24/7 unless we had had direct experience of it. The sheer mind-numbing fatigue that I have observed in friends and neighbours is compounded with worry about finance and about the future care which may or may not be provided for their partner or child when they are gone. It all adds to the stress, one Swallow's mother told me last week, when you just want to make sure that the child you love is as happy and secure as they can be. At this point, I'll refrain from doing a commercial for the Swallows charity, which has its headquarters in Westfield and is caring, or is for young adults and older children. Having a carer strategy is a thoroughly good idea, not least because it will, I hope, set out clearly what Baines' residents can expect from the Council above and beyond what is set out in the Care Act and other national legislation. It works better than the parish charter, I hope, or I hope it will do, at least as far as Westfield Parish Council are concerned. They're being rather critical of council statements, Baines' council statements. There must be a way to reduce the bureaucratic and bureaucracy as the Swallows mums see it, and bring together all the aspects of caring for a disabled person. If the dementia charities can do it, bring it all together, and we've heard today about work on this. If Macmillan have got very good information leaflets,
not to mention the RNIB, who have given me such a lifeline with my loss of support, loss of sight. Surely the Council can manage the same with this strategy, and also can make those with caring responsibilities feel valued and not a nuisance or an unnecessary burden for the council taxpayer. It frustrates me when, as happened at my surgery on Saturday, a resident presents with a terrible problem and I have to give them 4 or 5 different agencies who can help with some aspect of the problem. These papers that we have been looking at illustrate this problem. First of all, there is the difficulty of getting a statement of educational health needs, although we've heard that the waiting time has reduced. There is the whole controversy over SEND, which I would have been very interested to see how children who require such a statement, how many of them are on free school meals. Councillor Mansell's already drawn attention to the inequalities. Disability is a fast route to poverty, as I'm sure you all know. Then we see, sorry, I can't see, that's my problem. Then we see what exclusions are disproportionately affecting children with learning difficulties and ethnic minorities. We see that in the Youth Justice Report, the same thing applies, that those with learning difficulties are more likely to get caught up in the system. We see that the government funding has been reduced over the last decade. We also know actually from an earlier report, which has a national resonance, that children with learning difficulties who caught COVID-19 were more likely to be seriously affected or die. Health is at the root of each individual's situation, but I cannot see that the active travel paper, or the policy that is the next item on the agenda, is going to be helping the disabled in Redstock Westfield. And I myself feel fed up at the conduct of reckless cyclists who don't take into account that the little old lady waving a stick may not actually be able to see them. The Swallows' mums need their cars, and there's no way that they could cycle. And what about home-to-school transport? That doesn't seem to be mentioned in this active travel statement.
Eleanor, are you...
I'm nearly at the end, yes.
Only because you're talking about a different item.
But I usually have a strong light on the paper, and I haven't got it today, and I'm struggling. So it's assumed that everybody can find the information they need about respite care, support for learning challenged children and so on the Baines website. But people like myself cannot see the writing, and others, 20% of my residents don't have an internet connection. So what I'd like to say finally about this little group of mothers that I meet every week is that they want to be consulted. They want their annual reviews to be done promptly, and they want their views to be heard, and I shall be putting them in touch with Wendy Charles. So thank you for listening.
Thank you, Eleanor, and we will make sure that if we know you're going to read a statement in future, that your strong light is here for you to help. Can I ask Alison if you'd like to introduce the this paper, please?
Yes, thank you, Chair. Yes, this paper is an update following the publication of the co-produced carers strategy, and the work to produce that was done in 2024. This has got a few highlights that I just want to mention. Firstly, that it shows an increase in carer assessments and the numbers of carers receiving support. So that's really welcome. It sounds like the strategy is achieving what we wanted to, if actually we are supporting more people with caring needs. It also mentions the fact that we've had carer input into developing the service specifications for carer support. As with many of our services currently, we are at the start of a re-procurement cycle, and we will be procuring our carer services, but we can be confident that the specifications that we have for that are informed by our local carers saying what they need. So that's really positive. It also shows that we are making improvements to access to information and advice for carers, and also that we're improving data capture for the work that we do with carers. And that was one of the things that came out of our CQC assessment, that not all of the work that we were doing we could evidence because it wasn't being captured as effectively as it could be. So that, again, is a positive step forward. So I'm going to hand over to my colleagues now to talk about it in a bit more detail. Thank you.
Just remember, we've already seen the report, so we don't need a new presentation, just any additional information you want to give.
Thank you very much. So my name's Callum Graham-Robertson. I'm a programme manager sitting in the Adult Social Care Commissioning team. So just because you don't want me to provide any information which is already in the report, just provide any updates.
Is there anything that you think needs highlighting, the same way that Alison did?
Yeah, that's absolutely fine. Well, so first of all, I guess what I would say is I completely agree with Councillor Jackson's point about we don't understand what it's like to be a carer, which is why we've done so much co-production work in this area. We believe that carers have told us how they feel about being a carer, and also about the service they receive as well, which is obviously really important. I won't kind of cover over the numbers again because Councillor Bourne's already mentioned that. But what I will highlight is just a couple of areas which I think were pertinent from what Councillor Jackson said. So particularly around information and advice, I think that was something which you mentioned, having to offer kind of 5 different options for somebody in order to get the information they required. That was very clear in the conversations we had with carers and was integral in the strategy that we did, which is why we've been doing this work specifically around the carers portal. So it's one place where lots of information is held. So we were kind of recognising that, and also carers have talked about the need to make sure the route to assessment was really clear and really understandable both for the carers and also for the social care and health system more broadly as well. So those are areas which we are now focusing on, and you'll see them in our improvement plan for CQC, because again that had come out through CQC inspection as well. I think, to be honest with you, that's probably it.
Thank you very much. And now I'd like to invite the panel if they've got any questions. And Liz is first off the blocks.
I'm very lucky to be right beside the chair here because I get first go. Thank you very much for the report, and it is good to see that there's an action plan acting on the CQC inspection from some months ago. But one thing that is not there is a section on young carers, and I wonder, could you give us an update on what's happening with our young carers? Thank you.
Yeah, thank you for that. Absolutely. I should have said at the top, the carer strategy that we've been working on was specifically adult carers of adults, but there is an update on young carers. So there's a co-produced strategy for young carers which has been in existence for a couple of years. It's up for renewal this year, so a colleague is speaking with the young carer group at the Carers Centre at the moment, discussing with them how much they want to update and change and how much remains relevant for them. So that will happen over the summer, and then we can come back with a full update based on that after the summer.
That's great. Thank you very much. Thank you.
Thank you. Leslie.
Thank you for the report, and thank you, Councillor Jackson, for your observations. How will the carers strategy ensure that carers are not just acknowledged but actively supported in practical and measurable ways? And how will it address the needs of carers who struggle to use IT? We do rely on it more and more, and quite often it doesn't work very well either, even if you can use it. And what steps are being taken to ensure carers are meaningfully consulted in the development and implementation of the strategy? And I know that they weren't involved before, so it's a really good move that we're changing and we are consulting with people. And how will the council ensure annual reviews for carers and those they care for are timely and not delayed? Thank you.
Thank you. So I'll answer probably 3 of those questions, and I might pass over to a colleague for the 4th. So in terms of making sure carers are meaningfully engaged, I believe that we are doing that, and I think we can do more. There's lots of carers and there's lots of types of carers, I think it's fair to say. So we're working closely with the Carer Centre, hopefully you'll say that we're working closely with you. Working closely with the Carer Centre, and we also engage with other kind of more specific carers organisations as well across Spain, so I think we can do more of that. I think the challenge is staying engaged. We've got the strategy, we need to follow through on it, and we need to continue visiting groups of carers and saying, do you recognise the work that we're doing? Do you see the benefit from that? But we're committing to do that through the activity plan. Regarding IT, yes, absolutely. I believe the Carers Portal will be useful, but it's only useful for people who can access it. Baines, as a local authority, is doing improvement work to make our IT more accessible to residents anyway, but we're also working through the Community Wellbeing Hub with our partners to make sure that information is shared across the third sector to allow people to access information as well. So, again, I think that's an active piece of work we're doing. Apologies, I've forgotten your first question.
The first question you answered about ensuring carers are not just acknowledged but actively supported in practical.
Yeah, hopefully I've covered that through the... So just keeping them meaningfully engaged. And your 4th question I'm going to pass over, if that's okay.
Thank you, Karen. So the 4th question was really about annual reviews and making sure that it was a meaningful review as well for carers. As you can see from on page 30 around assessment and reviews, we continually increased the number of assessments and reviews we're doing for carers. We'll need to continue to do that because that's not all the carers that are using the service that have had reviews and assessments. So part of the work of bringing in the extra support into adult social care around our improvement plan is to see an increase in the amount of carers that we are doing, care assessments and reviews we are doing. It's resource, constant resource, and I think also it's that meaningful engagement about what's different, are actually, can we now, as we sit here today, say carers are having a great experience? I don't believe they are. I think there's much more work to be done, and I think the idea of some of IT and our portals are great, but actually we have a number of carers over 80, over 90, who that's not their main way of communicating. So we're adapting and sharing with the Carer Centre the support they're giving us to be able to make sure it's meaningful and it's making a difference and that carers feel supported. But it's very hard. I've just spoken to those 4 carers outside and it's a daily battle. So we as officers of the council have to make sure that we support and help in any way that we can, and that's what Callum is doing with his team.
Sorry, can I just come back on a couple more? So how is the strategy going to be addressing the intersection of caring responsibilities with poverty, SEND and health inequalities?
So I think it's fair to say that the carer strategy is a broad strategy, and maybe I should say at the top, we call it a living strategy as well, so it will develop over time. So we've got 2 key priorities or 2 key objectives which have been provided by carers over the work that we've done, but it will be added to over time. So I don't think it specifically talks about that issue, but as carers provide areas of concern, we're meeting that. Is there anything else to add?
Thank you, and I'll go back to when can we expect to see the equality impact assessment, because it's another one that's going to be developed at some point in the future. And surely the purpose of an equality impact assessment is to try and assess if there's a negative or positive impact.
Perhaps it would be possible to have that for the September meeting?
Yes, absolutely.
Thank you. So Kevin, I think you're the last person before me.
Thank you, Chair. Just two quick questions from me, please. The first one is around 4.2 and where the cooperation with the NHS bodies comes into the strategy. Any particular do they have a particular input into it, or is it subsequently from what the delivering of your strategy, if you sort of mean? Do they part of that? And the second quick question is just around the role of the carers centre and what it plays in that strategy, because I know nothing.
Yeah, thank you for those. Yes, regarding the ICB, I think that it's fair to say, so you'll see it slightly further up in the report, but some pieces of work specifically have also fed into our CQC inspection, so they went into our improvement plan, which is obviously local authority piece of work. But some of the priorities which were outlined by carers in the strategy and will be published in the activity plan relate to the whole system, and that does require, and to be fair, even some of the things which come through the CQC report, to be fair, they do require joint working across lots of different organisations. So, you'll see in the report that there's a couple of kind of mechanisms, I guess, for us doing that currently, but it may be that we need to do other things as well. So, for instance, through the ADAS Carers Working Group, which is local authorities coming together, we'll work across the region in that way. Obviously, through our connections with our ICB colleagues, we will be communicating with them. Specifically, I think in the activity plan, there's conversations around how easy is it for a GP to refer or send a carer to, a carer's service or to adult social care. That obviously requires working with PCNs. So I believe we do have those points of contact. So I think the relationships we have with the organisations will facilitate those pieces of work moving forward. Yes, and then, sorry, your second question, you're going to have to repeat it because I've talked too long on the first one.
Yeah, no, sorry, the role the carer centre play.
Yes, absolutely, yes, we shouldn't forget. So we were clear when we did the work on the carer strategy, specifically that it had to be bigger than the carer centre, not because they aren't doing a fantastic job, which I believe that they are, but because we wanted to reach every single group possible in Baines. So in terms of the wider context of the strategy, it's involved working with lots of different groups. Having said that, the carer centre have been an integral part of developing the strategy. Lots of the carers that we've spoken to are part of the carer centre. It's been supported by conversations with staff at the Carer Centre. Jackie, who's sitting behind me, has been quite vocal in terms of her opinions, obviously having worked in the local area for a different amount of time, and it's fair to say that in the activity that we need to deliver, any carers provision that we have procured will need to be a significant part of that as well. In areas such as kind of assessments and making sure it's easy to get statutory carers assessment. Again, the Carer Centre would expect that they play a significant part in that, on the basis that they would be, they would be holding a lot of carers who may actually then receive an assessment from us. Does that answer the question? Thank you.
Thank you. And I just have two questions. One of which is around unidentified carers. So, what more is being done? What more could be being done to identify those carers? Do we need, are there some sort of barriers? Are people afraid to be identified? And also, maybe there are other incentives that, should be being promoted. So that's one question. And then my second question, which picks up on the point I think was being made very early on in this meeting, was around the changes to PIP. And is that something that you're already thinking about in terms of the consequences and perhaps having more unpaid carers in the system?
Yeah, thank you for that. So in terms of unidentified carers, we know that that's a national issue and it's really important. And I think that through the carer strategy, what we were trying to achieve was how do we get the system to work well, or as best as it can for carers, but also acknowledging the fact that we are, by definition, only talking to carers who have been identified as such as well. And actually, again, you'll see in the report, but it's only, I think there's one line in there. We are doing some work already to try and identify unidentified carers. So particularly through the Community Wellbeing Hub, they've updated the way that they collect data to include an opportunity in referrals to identify as being a carer. So that helps us to find people. And the Community Wellbeing Hub have also been running an initiative at the RUH in Bath, where they speak to residents as they're coming through the front door, and again it's just this actively trying to reach people who may not know that they're a carer but articulate information which allows them to recognise themselves as such if they want to. And then obviously the work, anticipated work with GPs and the referral form into the community wellbeing hub. Again, it's another opportunity where if a GP knows that they can tick a box saying this person is a carer with their consent, it then allows us to recognise them through Rivium and the Community Wellbeing Hub. So there is some work there, but we could certainly do more of that. And I think as we move through the priorities set out to us by carers in Baines, there will be more opportunities for doing that as well.
Thank you, and it's very reassuring to have Kate from 3SG nodding behind you as well. What about PIP and the consequences?
Yeah, so I think we still need to think that through, to be honest with you. But what we are trying to do is make the system and the way of carers getting the information and advice or the support that they need as effective and efficient as possible, and that should be what we need to do anyway. But obviously, because you're right, we should anticipate that there will be more carers, and again, kind of to your previous point as well, if we seek to identify more unidentified carers, we would also expect that that would have an impact on the system. So yeah, we are considering that in our planning anyway, on the basis that we're expecting to see numbers potentially increase.
And thank you, Callum. I think this is your first time speaking to us as a panel. I think you've done quite well.
Thank you very much.
Thank you. So we now move on to the next item, which is the active way. Alison, would you like to introduce this?
Yes, I'll just briefly introduce it. The Active Way is it's a partnership between Active Travel, because you can't say it, Active Travel, thank you, and Leisure Services. And it's, I think, a really interesting and exciting initiative, which does a lot to improve health and well-being. So I'm going to hand over for you to take it through more fully. Thank you.
Thank you, yeah, and thank you for inviting me today to talk about quite an exciting project we've got running. And rather than perhaps just reliving everything I sent through in the presentation, I'll perhaps just talk through a few challenges that we've seen over the course of the project and how we've overcome them and how we've developed since we've received the funding. So we're very lucky and privileged to get a lot of money actually from Active Travel England back in late 22 to deliver the Active Travel Social Prescribing project. I think Active Travel is a hard word to say. Try and combine it with social prescribing is quite different. And we really set off as a really steep learning exercise about how we can really break down barriers, engage a really target our interventions to the communities that needed them, and address four key sort of priorities or four key objectives around identified need and in relation to underrepresented groups, areas of deprivation, people with low levels of physical activity, but also try and make that link to our local infrastructure. The pilot project's based down in Summer Valley, so obviously we're really rich in local outdoor spaces, green spaces, the active travel routes that we have down there, and how can we get more people onto them that needed that intervention. So some of the key challenges we had, we set up almost from scratch. So we built new systems, new referral pathways. We trained ourselves up to be ride leaders and walk leaders. We engaged and commissioned a whole range of different providers to operate in that area. And then we sort of tried to then engage all the primary care network that we were working with over in the Three Valleys PCN. And we very quickly recognised it was a very sort of busy field, I suppose. The social prescribing link workers and care coordinators were extremely busy. So we didn't expect it to see so few referrals come in those early stages, but really bottoming that out is really about how the priority of active travel and physical activity levels in those consultations that those social prescribing link workers might be having in their consultations was probably quite low on that priority list of things that the patients wanted to discuss. So we thought we'd actually be far more proactive in engaging the community groups, the organisations, the third sector, directly where those represented groups would form and meet more regularly. So we go out and we actually talk through our interventions firsthand to those participants and try and onboard them and sign up referrals. We're really pleased to say it's been really effective. We've actually delivered over 1,800 activities to over 1,000 individuals in the space of well, just over 2 years now. But we have noticed a whole range of things we've had to overcome in that time. Not necessarily to try and get people through our doors, but how we identify those needs better, more quickly, and how we find more suitable and appropriate activities for people to take up those opportunities. So we really refined our triaging services. So when referrals come in through a community wellbeing hub, we've built a sister system to that, I like to call it, in that we've got a single form access point to our service, and then we can triage that out to over the 17 or so different activities or interventions that we have on offer. And by engaging and talking to participants more directly, we can identify those needs really quickly and provide the support and advice as early as possible. And we've certainly then seen our take-up rate of those activities climb from about 40% right at the start to over sort of 85–90% now. And by that I mean people that we speak to then go on and do an activity rather than think about it for a few months or then not take it up. So we've worked really hard to make sure people come along. It takes a long time to build the trust, and the confidence in people to go out and walk with new people in new sites and with new equipment. But we feel like we've really sort of worked very hard to achieve that and overcome that. We also didn't preempt a lot of varying needs that people come to us with. People are far more complex when they come to you than perhaps the referral form might state. And it's actually matching people's ability with their confidence, with their demographics, and bringing people together in a shared space for a joined up purpose is actually quite challenging. When we're talking about breaking down barriers and accessibility and inclusion, it's got to be in the right place at the right time with the right people. And actually doing that is actually quite a challenge. So we've worked out that actually we're far more cohort-led, so we target those interventions to specific cohorts of demographics. We can build that really quite well, and we can work with those already formed groups in offering interventions in their own settings in a far more flexible way too, rather than trying to force people together at times that they might not be able to come to us. We can be a bit more flexible and provide for that group that's already in situ. Speaking to Councillor Jackson's point earlier around how we support those communities like Swallows and the parents and carers of those groups, we came to those sorts of conversations around identifying those varying needs. So we have activities that people can come to with the person they care for, but equally there's an opportunity for that carer to also come along and take a ride or go for a walk with them too. So it's that broad offer that I mentioned earlier that we can cater for. But also it's about understanding people's motivations and what outcomes we'd like to see from it. We didn't really ever set out to improve the lives of absolutely everybody. We always had to be very targeted and very sort of not reduce those ambitions, but be very realistic in what we could set out to achieve. Yes, we can improve the physical and mental well-being of participants that come through by offering those interventions that people really care for. Yes, we can improve physical activity levels through those interventions by providing those sustained long-term behavioural activities and provide that ongoing support. But it's always going to be very targeted to those that needed it most and would have the greater impacts. And that's what we're seeing now. We're seeing that those people that we have intervened with are really seeing those changing behaviour changes, those longer-term benefits of taking part in those sustained activity levels. We're working with the University of West of England to monitor and evaluate the pilot, and they're working now towards the final evaluation because our pilot is up in October this year. We're looking at seeking some further funding to carry that forwards because we do think the long-term outcomes are still being realised. It's going to take a long time to understand what the long-term behaviour changes are to the interventions and whether it's having that significant impact on people walking or cycling more, certainly around the Somer Valley where we've been intervening. But we are seeing some emerging evidence. We're working very hard at the moment to gather case studies and get some feedback from those people that have been taking part, and actually it's all been really amazingly positive, from quite life-changing stories from people coming from the brink of mental health crises to those that have found really strong social connections from the groups we're forming. We are seeing some really positive outcomes emerge. Coupled that with some of the more quantitative data elements that we can capture, such as the survey responses we're getting, but we're working with providers who provide very robust digital data sets, so tracking information from bikes or sort of wearable devices provides us with that really strong evidence that the interventions do lead to sort of increase in physical activity levels, and more opportunities to go and seek new routes and things, so we can track where those bikes have been, and we can see how far people have actually walked and ridden as well. We've had to change quite a lot over the course of the project too, so we recognised quite quickly there was quite a gap in our provision. So yes, we put on lots of walking and cycling activities, but we recognised the target groups we were trying to engage with, there was almost a prior step to that. people weren't always capable of going on a walk or getting on a bike. So what could we do to support those people? So we included things like seated exercise and more sort of triaged and more sort of coaching services, so we can help people get from their home to a bus stop, or out there. We can meet people on their doorstep with some providers, so it's a much more sort of handheld service. The seated exercise has been amazing to see, because we work with the Pain Cafe over at Hope House. We've identified a cohort really early on, and over the course of 20 weeks they've gone from really sedate seated exercises to coming on to walks with us, so we can see firsthand the progress people can make by that regular intervention. And it's been a really, really powerful and compelling kind of example of what we can deliver. But really we're setting out now really how we can preempt any future delivery priorities, what they could be. So whether that's from a sustainable transport perspective in increasing the active travel routes across the district, and how we can enable and break down the barriers and inclusivity into those new networks. Or it could be around preempting what the NHS 10-year plan might do around preventive care in the communities. How we can sit within a wider framework and a wider system of social engagement, social prescribing, triaging into a range of social activities that would help people overcome some really serious mental health and physical disabilities, but also provide that support to the communities and build the resilience in those communities to deliver them. I think the system that we're working with 3SG is starting to emerge about how that could work, and we've got some really good evidence and really good practice going on, especially in places like the Somer Valley, where we're seeing that happen. We've had lots of different green social prescribing pilots run across the area, and we're working really hard to sort of cement that more into a more solid offer for Baines' residents. And we recognise people's motivations, I mentioned earlier, are all different. It's not about me telling you you can go out and walk and cycle. If that's not what you're really interested in, you're far less likely to carry that on. But if we can build an element of interest into that, whether it's a nature-based walk or a creative walk, or people like the idea of doing some green social prescribing, but if we can build lots of things into that actually combine a number of different motivations and elements that we'd like to see as outcomes, as in increased physical and mental health, improving physical inactivity, broadening and opening up the local areas, then I think we're achieving a huge number of aims in one sort of delivered project, as it were.
Would you like some questions?
I would, yes. Yeah, so I can ramble on for ages. So
I'd wait until you pause for breath. Okay. Michael.
Can I just say, firstly, what a great work you've done with active travel, to be honest. And this is more of a sort of anecdotal than a question, but I know from talking to people involved with both Snap and Stroll and sort of Nordic walking groups, and also the cycling that happens up at Odd Down as well, that it's had a big impact on both mental and physical health of participants that are in those groups. And I kind of commend you for supporting those organisations. And certainly as a Somer Valley councillor, I know that there are a lot of activities going on in the Somer Valley. And obviously, as a local councillor, I'd be very keen to support as much as you're doing to kind of promote and encourage more of those groups to take part, because I know it is having a big impact on quality of life for people, are getting them out and exercise both mentally and physically.
Well, thank you. It's really nice to hear that you're seeing that and having those conversations with them. And I think we are really proving how we can deliver it in a far more flexible approach. We know when we've got those resources in place in, say, Mitton and Radstock, that might not be so accessible for those in more rural communities. So we're now developing our approach to how we can help communities in more rural areas by taking bikes to them, or taking walks and identifying walk leaders within those communities. We know most community groups or most community spaces have groups that meet that could be injected with a little bit of active travel or well-being into those. So how do we build that resilience? How do we have those conversations with those community leaders and community groups, and providing those opportunities? And I think that's what we've really sort of started to do, is go to them and develop routes for them in their own communities and areas. And that's really helping support more people, building more robust sort of resilience in those communities to deliver it.
Thank you both. Liz, you're next.
Well, it looks like it's Somer Valley Support Group here, because I also represent Poulton, which is in the Somer Valley, and I want to thank you for all you're doing in the area. It's really excellent. And it's good to see such enthusiasm, and I can see why the pilot is so successful, because I'm sure you and your team are so keen to make it work. I'm assuming you're, I'm sorry the pilot is coming to an end, but I'm assuming you're getting money from, is it Active England? Is part of where your money's coming from, and hopefully the pilot will carry on, that this is not all going to disappear. But the second interesting thing I'd like to find out from you is, you say one of the outcomes, the good outcomes, is investment in the local economy, and obviously in Somer Valley we very much like to see that. I wonder, could you expand on that, and getting in contact with local groups? 3SG is really good to go with as well. Okay, thank you.
No, absolutely. In terms of the investments in local economy, just aside from the bikes that we've bought and things all from the local suppliers in the area, we're also employing local people through some of those providers that we engage with. We know by empowering the people in the area to get out more, do more walking, we've got lots of stories about how people that we've lent or provided tasty sessions to, certain on things like e-bikes, have then gone on and bought their own e-bikes, now they commute to work, and they use more of the local area. So we're having direct direct investments through the funding that we have received, but then there's obviously those knock-on investments too through the providers and the support that we're enabling within that area. In terms of funding, so the initial grant was through Active Travel England. They haven't committed yet any further support for the pilots going forward. We're one of 11 local authorities to receive funding, so I think they are looking very closely at what the outcomes are being seen. A lot of the pilots have suffered quite severe delays, so they've pushed back the final evaluation, I think, to August next year, so to August 26. We're looking to report in the spring of next year, because we set out to deliver within a certain time frame, which we are sticking to. We're looking towards the west of England at the moment, and they're a combined authority about what support they could provide. Obviously, there's the City Regional Sustainable Transport Scheme funding that's coming up. A lot of that, obviously, is very capital orientated, but I think there is really goodwill between the West of England Partnership around that more behaviour change funding should come alongside that if we want, as I said, to improve that accessibility and break down the barriers to get more people on it, rather than the same people using those systems. And we need to support more behaviour change projects. The council, Somerset Council, have been hugely supportive in what we're trying to do and assisting us to try and find that funding to carry on. But at the moment, we are looking at how we can provide that scaled-back approach, possibly beyond October, depending on where the funding lies. But we will be taking a business case back to Active Travel England to seek further investment if they are willing.
Thank you. Leslie, you're next.
Yes, thank you for the report. It's clearly something that's very important, and certainly I'd like to see a long-term impact on this. I'm a councillor in Radstock, so like Rome, it's built on several hills, so if you have a bike, depending on who you are, you probably need an e-bike. And it's good to see somebody in your presentation who'd bought an e-bike following the interventions, but not everyone can. And if you're going to have an electric bike, you've got to have one that costs more than £1,000 for it to be any good, and the motor's going to last. So it'd be good if you could persuade WECA to provide some funding, because we do have areas of deprivation around Radstock. So my main question is, you talked a little bit about it, but how are you measuring the impact of what the initiatives that you're bringing in, and what can you do around affordability? And the third thing is getting the messages out to young people. When I was a school governor in a rural area, most of those youngsters have not gone out for a walk in the countryside. It's an alien environment. And similarly with the youth service, and some of the things they are doing now are helping to change that. But young people now, they're so used to using electronic equipment that they're going out for a walk and listening to a hedgehog scurrying around, or a woodpecker, as we have various of these in around Radstock. You know, it's just not anything they even think about. Thank you.
No, thank you. It's a really important point. I think you're right. I think access to nature and those open spaces is hugely enriching for young people. Because we're being very targeted as a pilot project, we're engaging people like Youth Connect South West, and we're offering their young people a chance to come on walks. We've done Snap and Stroll sessions with them. We've done bike training with them and take them on lead rides as well. But working with colleagues across the active travel team who deliver things like the motor shift, promote the motor shift styles at local schools, we hope to build local travel plans with those schools as well in the area too, so we can really try and embed in that behaviour change at really early age, working alongside the bikeability team who go in and do bikeability for those schools, certainly for year 5 and 6. And I know they've got quite high targets to achieve about 80 or 90% of those within the primary setting. In terms of affordability, I think it's an absolutely crucial point around it. There is an obvious barrier there to include taking up active travel. If you're looking at e-bikes, especially around the Summer Valley, it's not an easy place to get around. Even as the most fit and able person, it's a struggle, and there is a natural barrier there. But by providing these taster sessions, we really sort of trying to open up those conversations with people around, well, what is it that's stopping you getting into Bath, for example, by the bike? Is it how can we connect you more to your local sustainable transport connections? So with the developing sort of active travel plan and all the links projects that are going on about what that new infrastructure will drive, how can we get to your bus or to your connection point in a far more sustainable means? We hope that obviously local bus services are where they are, so we need to try and provide those opportunities and those travel choices for people. We've commissioned a whole range of people that provide that on-the-ground training, but we can also lend people bikes for a month at a time, and that's sort of a rolling loan. There's accessible bike shops within the city here, within Bath, that people can go and hire bikes on a long term as well. We've got all sorts of range equipment that you can demonstrate the range of affordability options between that, and yes, we want to have conversations with the West of England around what schemes might be coming along. I know some other parts of the countries, they do offer subsidised bikes or voucher schemes. There is a means for us to develop a community workshop where we can upcycle bikes and provide them back to the community either for free or low value too. So they're unlike to be sort of electric bikes, but they're pedal bikes that we can then help and develop that confidence and skill to be able to not be so intimidated by the hills around the areas. But we do understand that obviously the electric bikes are largely out of reach for many people. We hope to see the e-scooters and e-bikes on the street schemes being further expanded, so there'll be more access and opportunity for those, especially for the e-bikes in the Summer Valley. So along with those different schemes, we can see how we can bring in things like voucher schemes or subsidised schemes that would help people have more access to them. In terms of measuring impact, sorry, there was the last point there, wasn't there? So I mentioned we're working with the University of West of England. There's lots of data points that we are collecting along the course. But aside from sort of the case studies and the testimony we're receiving back from participants directly, we've got a participant questionnaire that people are filling, and that's before an intervention, 6 months after, and then a further 12 months after that. And that way we're able to track and monitor any progress within their behaviour change. We're working with the local evaluation partner in University of West of England, but Sheffield Hallam University are working as a national evaluation partner. So as well as the local work, there's a national piece of work going on around what the wider impact of the pilots is having. We're also putting in place sort of more direct pre and post monitoring. So we're doing the ONS4 Wellbeing levels. We're also tracking happiness and anxiety levels amongst participants before and after our interventions. And as I said, working with those data points as well through the bike tracks and our wearable devices that we've got out through Key Active as well. So there's lots of ways that we can capture and measure the impacts and long-term outcomes. We're doing qualitative sort of questioning as well, interviews with the providers and local participants as well as the officers involved with the scheme too.
Are you happy with those answers, Leslie?
Can I just, thank you for the answers. Can I just go back on your data as well? Because in the presentation you've got data on age, on women and men, and on the A&E people, but you haven't got anything there on disability or LGBT. Have you got that, or have you just not put it in the presentation, or have you not collected it? Thank you.
Of course, so a lot of those demographics are captured within our referral form, so the age and ethnicity and obviously location of the participants, but the disability or long-term health condition isn't captured within that referral form. So that way we're capturing that within that questionnaire that's going out to participants before they start and then thereafter. So at the time of putting this together, we're just analysing some of that data back. Unfortunately, due to the nature of some of the participants, the format of that questionnaire isn't the best. So it's quite a long questionnaire. It's about 50 questions long. So the likelihood that the with the most severe needs are unlikely to answer those questions. So through that, we're trying to support ways for us to be able to capture that. So we're going to those organisations to help us fill those out on their behalf. But we can certainly capture those long-term conditions that people are coming to us with, and some of the other outcomes as well in terms of disabilities.
Okay, thank you. Kevin.
Thank you, Chair. Just one question and just one observation, really. The question is around, you did say that you sort of stepped back a bit at the beginning to look at how people could even get out and even start to access walking or whatever. How do, looking at the other side of things, when people are hooked and want to carry on with all these wonderful new habits, how do you fit in with things like, is it the council that organise the overall travel plans and safe routes to cycle and walk in sort of Bath and North East Somerset? Are you fitting in at the moment, or are you waiting to see the end of the pilot and then inputting? And my final just odd comment is just that if you do have any discussions around safer cycle routes and things, cycling along the road to the park and ride at Odddown in the cycle lane, I have to say, is ridiculous, because there's so much gumph and rubbish that gets chucked on there by cars going past on the other lanes. I have to cycle on the road, otherwise I risk getting punctures or falling off anyway.
So yes, we are part of that process and that discussion. We sit within the strategic transport team, so in the development of those travel schemes, we were considered. The active travel master plan that's coming out, hopefully will certainly reference some of the work we've been doing in terms of the social prescribing and breakdown accessibility and making sure that there's improved access for people. But I know there's a lot more we can do. I think we've got quite good ambitions around how we can support that team further into the future when these new schemes do come on board and get developed. So which communities we can engage and how we engage them, I think, is really important. What sort of conversation we're having and who we're designing those schemes are for, and how we can, as I say, onboard people really quickly and make sure they're supported in that activity. Certainly, there was a question around the Odddown cycle path up to the park and ride, but I think if it's my choice, I'd perhaps do the off-road route. There's a really nice twin tunnel, 2 tunnels. It's a bit longer, but take a bit more time to get into Buffett. I see, from Poulton, yeah.
And you sort of suddenly find you're in little avenues, so you can do the little greenway between some all that stuff. Or you can go off to Froome on the railway line, but there's nothing in the way.
No, so it's a long route round, I take that. But I think with the developing plans, there are going to be far more accessible routes and quieter routes coming along, certainly with the Summer Valley Links project and how that might make the connection with mobility hubs as well. So hopefully it's the travel choice element that we really want to try and provide, and the confidence we can provide the skills. If you need to know how to navigate the traffic a bit more confidently, we can certainly help with that too.
Thank you. Now, I've got a couple of questions. One is, so just picking up a bit on Leslie's point around the various groups and how that data is recorded. So you say here, one of the opening slides, that you are targeting people living in deprived areas with low levels of physical activity, yet in this presentation, there's nothing that captures the sort of like household income, so we've got nothing really that correlates to that particular point. So how do we know that it's not just the perhaps higher income earners that are actually accessing the active travel opportunity? And then my second question is more of a sort of future-proofing, but future-proofing our population's health. So we know that in schools there's a reduction in physical activity, so PE, sports, lots of sports clubs now are becoming quite prohibitive in terms of the cost. I know I was talking to somebody from a swimming club, for example, and actually they have hardly any children now from state schools in the club because it's too expensive. So how are we ensuring that we are thinking about the sort of like upcoming generations in terms of our provision for active travel, active way.
Thank you. Yeah, and I think to take the first point to begin with about targeting in the more deprived areas, we do capture some of those economic assessments at the end from our the participant survey. So we asked there about the income band of participants that have come through. We also do it through how we're targeting, which sort of organisations and groups we're actually targeting. So it could be some of the local charities that we go along to. We were at the jobs fair just last week trying to target participants through that way. So people that come to us that are out of work or in low-paid employment, talk to communities in Radstock around sort of Youth Connect South West, as I mentioned. So largely those are from people from deprived backgrounds. Our pilot was really built on the foundations of a feasibility study that we conducted back in 22, which identified those key demographics and key target areas, and which ultimately won us the money in that we built a really robust plan about how we can target those specific communities that had that identified need. Obviously looking at strategic evidence base around where areas of deprivation were. Obviously we know there's deep pockets within the communities across our district. But couple that with the opportunities of health inequalities and the landscape in the Somer Valley, that's where we chose to run the pilot. So I think naturally we'd want to target those demographics in the areas that we know that they're widely more represented. So those that have say low take-up of those other community groups, that sort of sporting activities where there's gaps in that provision as well. When I talk about sort of the onward journey about how we can improve population health in young people, I think it's about providing that education really early on. How can we encourage those young people to get out more and discover nature? And I think it is identifying those leaders within the schools, within the community groups they might come along to. As I keep mentioning Youth Connect South West because they do a great deal of work. They do put on a whole range of different activities and offers, and they engage with a whole range of different young people too. So I think we've got to tap into what people want to do. If there's an interest in creativity, we can provide that. If there's an interest in sort of sport or leisure, we can provide that bike for them to get out and do it. If it's about nature, we can link them up with local nature enthusiasts too. So it's about being flexible in that approach, but equally accommodating too. So we can provide what it is that we can do, promote the benefits of being outdoors and taking up that physical activity. I think is crucial to it. Education is key, but also providing that opportunity through delivering bikeability or doing a lead walk with them over a lunch period or a lunch break is really good, and that's what we've been doing with Youth Connect, for example.
Thank you, Tim. And I think you too have not spoken to our panel before. I'll think about your marks out of 10, but it's pretty good too. Thank you. Right, now panel, we are now on to the last two items of the agenda. Firstly, the minutes from the 12th of May. First of all, can I have some indication that these are broadly a correct depiction of that meeting? Liz?
Yes.
Oh, they are. Sorry, I thought you were going to...
Sorry. I thought you wanted me to...
I do.
To propose.
I would like you to propose, but I think Kevin is going to have spotted an error.
Well, I've got a couple of accuracy. One is on page 58.
These inaccuracies?
Yes, not questions, sorry. Let's go down to 58. My computer gets there. It said somewhere that I was asking if families that qualify for auto-enrolment into free school meals would receive a letter to inform them. He also asked who had overall control of this process. My main part of the question was, what if the families are enrolled by mistake and don't qualify? So basically, that was the question that Chris Wolford, I hope, is coming back to me on. So if an error is made, who takes accountability? If a letter is sent to a parent thinking they do qualify and they register or whatever, and they don't qualify, then who takes ownership of that?
I think we'll just make sure that Chris understood that question, and then we'll have an answer by the next meeting, which, of course, as you know, focuses on children's services.
And the only other two quick ones was one on page 65, which, when I asked it, was around trauma-informed approach. Sorry, be there on my computer. I highlighted it on the thing. Yeah, about halfway down, I commented a lot of stories placed upon trauma-informed practice. Yes, but the question I asked was, do we need a similar trauma-informed approach to practice across education and all services in social care? Which didn't actually get a direct answer from, but hopefully it's recorded for some time in the future.
Thank you, Kevin. Anything else?
A word seen, I think, has been missed from about 3 bits up, where it says Councillor May commented that he has the partnership working in practice. I think seen the partnership working in practice, but that was a guess.
Okay, well, I'll ask Mark just to go back through his notes and correct if... But with those changes, are we all minded to support that this is a correct record? Yeah. Yep, okay. Good. And now we move on to the panel work plan. And I want to just emphasise something that I know Leslie mentions pretty much every single item. Can we make sure that we have an equalities impact assessment with every single report, unless there's a really good reason why there shouldn't be one, and then can that reason be part of that report, please? There is a line, isn't there, that says equalities impact assessment, and if it's not appropriate, then that's a good place for that to be filled in. Right. Then, if we then move on to what is already in our work plan, obviously we've made a note of several items that we're expecting in July and then in September. Don't forget, we're not having a meeting in August, even if you ask very nicely for one. So the next meeting is around children's services, and I'm just looking to see what we've got planned on that.
So we've got the modern slavery.
We've got the modern slavery item, absolutely.
I've got some needs to talk about the Trailblazer. I think that's being funded through WACA.
Okay, so we've got the Trailblazer item that Councillor May was talking about.
And the school surveys,
And the shoe, yeah. Or the replacement name for...
Plus HCRG are attending.
And also HCRG are attending. So is there anything else that's not on the work plan that you think ought to be on there, that we've not spoken about? Oh, sorry, Chris.
Can we have school exclusions and attendance and free school meals update?
I think that would be very, very useful if we did, yes.
In view of the, latest legislation.
Okay, and that could, I'm not sure that one will come for July, but we could certainly
make
sure that it comes
for... Well, it may not, but it's come from...
We can ask Councillor May to put an update on those items in his report. Yeah.
Thank you.
Liz.
We've got update on safety valve on our work plan, but we haven't got an actual date for it.
Well, I think we could ask Councillor May to put it in his update. He may not know yet. He may not have been given the advice. Okay, anything else from anybody else? Lovely. And